Yeah. Okay.
Brian Restrepo. Brian.
I'm
Hola.
going to mute.
Adelante.
Can you see my screen?
Yes.
Okay, good. Yeah, it's just trying to try her, but I'm not the first speaker anyway. Trying to see if it works. It's working. So beautiful. Okay, I will stop and then and let's have Norville take care of this. All right,
I will continue giving admission to the rest of the participants,
no problem.
but since it's 10:30 a.m., I think we should start, right?
Yep. Did you see that?
Yeah.
Did you see my screen in Norville?
Yes, I saw it
Okay, good. So it
without any
works.
problem.
Yeah,
It worked, yeah.
yeah.
Let me check here to share the screen and to start.
Sorry, my background is blurry, but I don't know what to do.
Never mind.
Yeah.
Let me share. Okay, can you hear me now? Better?
Yes, I do. I do hear you.
Okay. So
But
welcome
Professor
to
Mohammed
everyone.
is
Oh, Professor Mohammed, can you hear me
Yes, I
now?
can. I can hear you very well. Thank you.
oh beautiful.
Thank you. Uh, okay. So welcome to everyone. It is my pleasure to start this webinar. We have many very important speakers and experience with a lot of experience in the field of the chemical industry and chemical risk exposure. So we have the great support from two ICO scientific committees, the ICO scientific committee of occupational health in the chemical industry and the ICO scientific committee of occupational medicine. We also have the support and participation from the International Pneumoconiosis Observatory. Um, and of course, this is the objective of this webinar is to review all the risk, chemical risk exposure and the potential opportunities for improve the occupational health risk management inside companies from different sectors, including agriculture, construction, mining, and others. So first of all, uh, this is a invitation, a formal invitation for look for information about the ICO 2027 Congress, which will be held in Mumbai in February 2027. We will share with you the formal flyer and announcement by the chat. And thankfully, we also have the participation of one of our ICO board members. Let me introduce you to, oh, sorry, I get out of the presentation. Let me introduce you to Dr. Ralapali Rajesh, which is occupational medicine physician from the Reliance Industries Limited, mm, one of the largest private sector corporations in India and a Fortune 500 company. Has led stellar initiatives and achievements for the organization in the space of occupational health and well-being. He has been ICO board member for the triennium 2024 to 2027 and currently serves as the vice chairperson of the ICO 2027 Congress. As ICO National Secretary from India, he had been commended for the best results reached in membership recruitment during the triennium 2012 to 2015 and 2015 to 2018. His member steering committee for World Economic Forum on Mental Health, past president of the Indian Association of Occupational Health. He was awarded as Dr. C.K.R. Centenary Award for Lifetime Achievement from the Indian Association of Occupational Health, IAOH Prestigious Orations Awards Fellowship of the same organization, P.V. Thacker Memorial, J.C. Kauthari, C.K. Ramchandran, ADM Oration, um, OHSF Mumbai Best Resource Person. He received the Hall of Fame Award 2024 for Healthy Workplace by Arogya World India Trust in collaboration with the Public Health Foundation of India for Reliance Industries Limited. He received the Duty of Care Award, highly commended Special Mention Awards received in 2026, 2023, and back in 2016 from the International SOS for Reliance Industries Limited. So welcome, Dr. Rajesh. It's a pleasure for us to have you here in this webinar.
Dr. Novel, you have to allow him. He tried to join in Zoom, but maybe waiting in the lobby, like in the messages.
Nikunj, I have joined.
Okay. Yes.
Yeah, good evening, Dr. January. How are you?
Doing well, thank you. How about you?
I am fine.
Beautiful.
Sorry, Dr. Rajesh. Welcome. We just introduced you with a short summary of your CV, and we are very honored to have you here as an ICO board member for kicking off this webinar.
Yes, thanks for that. And thanks you for all for this webinar. And one thing which every one of you are well aware that we are organizing International Congress on Occupational Health, ICO, first time in India in last many years, 100 years. And that is in Mumbai next year from 14 to 19 February. And I'm the vice chair of the ICO Congress Committee of National Committee. So request, many of you must have registered already, but if those who have not registered, please register for the Congress. Be there in the Mumbai on 14 to 19 February. So we'll take care of you. And there are many scientific sessions are there already. Martin Hogan and team has finalized many scientific sessions for the afternoon, and we have received more than 1,000 abstracts. And they have already reviewed all abstracts. So that's the thing. And deadline for early registration is 15 September. Or I think so few of them may be coming to Malaysia also in the next month, where we are meeting for ACOH, Asian Congress on Occupational Health at Malaysia, Kuala Lumpur. So that's a brief nutshell. You can proceed further.
Thank you, Dr. Rajesh. We will share with all the participants the formal document of this flyer that we are sharing in the screen. So
Yeah.
thanks, Dr. Rajesh. And also, we have the presence from Dr. Ning Jung Kumar Desai, who is the current ICO Scientific Committee on Occupational Health in the Chemical Industry Chair. He's the Vice President of the Corporate Medical Services at the Reliance Industries Limited. He is also the organizing secretary of the ICO 2027 Congress. Remember that Dr. Rajesh is the vice chairperson, and we also have the organizing secretary kicking off this webinar. He received the Indian Association of Occupational Health Best Resource Person Award at the OCCUCON 2024, and the recipient, he's also the recipient of the BEL IND Award 2021 for his research work, and HUL Award 2018, and for Best Scientific Paper. Welcome, Dr. Desai. Desai, it's a pleasure to have you here for kicking off this webinar.
Okay. Thank you, Dr. Norville, and good morning or good afternoon or good evening, all of you, because a different zone in the across the globe. And just it's a very enthusiastic moment for all of us because we jointly collaborate this webinar with OH in chemical industries and OH in occupational health medicine, then Peru, ICO National Secretary, as well as International Depository of Pneumoconiosis. So such collaboration, we have to do more and more activity quarterly, 6 monthly. But before start, just I will give a brief about the OH in the chemical industry. So this is the new committee inception in ICO in 2023 beginning. So they have started this committee OH in chemical industry in 2023. Since inception as a committee, we did more than 10 webinars, totally focus on the chemical industry, innovation, workplace improvement projects, as well as how we make the safer, healthy and sustainable workplaces. This is the main, our committee motto, more than 50 plus members as of now. So I request all of you, those who are not a member of our committee, please join so we can have a more collaborative efforts, we can have a more webinar and we have more learnings. That is, and I'm happy to share Dr. Hanvier Gasana, he is the secretary of this ICO Scientific Committee, OH in chemical industry. Such a learned person is secretary of our OHCI committee. So once again, I am also again inviting you, all of you, for the ICO 2027 from 14 Feb to 19 Feb in India. Already brochure is displayed by the Norville, and he will again share at the end of the session in chat as well as to the mail to all of you. There is a group discount offer available, more than 50, minimum 15 plus people if register in a bulk, then there is a group discount is also available in US dollars. So please take a benefit of this advantage, and we'll meet in person in next year in ICO. So this is the beginning of collaboration. We will have more collaborative webinars in future also. And thanks Norville for taking all the efforts in pain to collaborate all of us and organizing this webinar, and wish you all the best to all the speaker, and thanks to all the participants who have joined the webinar. Thank you. Thanks a lot.
Thank you, Dr. Desai. It's a pleasure to have you and Dr. Rajesh even kicking off this webinar. And of course, this would be the first step for future collaboration with different activities with the Scientific Committee of Chemical Industry, Occupational Health in Chemical Industry, Occupational Medicine, and others, of course. So for starting this webinar, it is also my pleasure to introduce you to two of ICO members from Peru who will support us as moderators during this webinar. We will have Dr. Cynthia Vasquez, who is also ICO member of Peru with a Master in Occupational and Environmental Medicine. She works at the company ESCO in Cajamarca, part of our Highland or Andean Highlands in Peru. And we also have the support from Mr. Uriel Yankee, who is a chemical engineer with wide experience, especially in the public sector. He has a master's degree in occupational safety and health, and he works at the Social Security of Puno, which is part of the southern Andes of Peru. So welcome, Dr. Cynthia and Mr. Uriel. You can start with the moderation, please. I will stop sharing.
Thank you, Dr. Norville.
Gracias, Norville. Thank you very much.
Thank you. You can start with Professor Jambier. I will share his CV.
Good afternoon, everyone. Thank you for Norville for the introduction. The importance of the United Nations globally harmonized system and safety that shifts life in protecting people and the environment by establishing a single global framework for communication chemical harms using standardized hardship pictograms of labels and providing consistent and relief safety information through safety dashboards. The shared experiment from agriculture, construction, and industry, it is my pleasure to introduce our first speaker, Professor Jambier Gassana. Professor Jambier Gassana is a triple qualified expert holding an MD and PhD in environmental and occupational health and medicine. As president and CEO of the Florida Basal Global Applied Prevention Center he champions primordial prevention worldwide. His leadership spans 3 continents, including founding environmental and occupational health departments at Florida International University and Kuwait University. A veteran consultant, the WHO, the World Bank, and USAID, he specialized in high-impact training in exposure enhancement through specific processes, environmental, social, and governance, and occupational, environmental, and behavioral disease. Recently honored by the Society of Occupational Medicine in 2025 for his outstanding global contribution. He remains in leading figure ICOH research and practice, presenting an ICOH and ICOH to promote occupational health capacity building in underserved regions around the world. Professor Gassana, the floor is yours.
Thank you, Doctor. Let's see, sharing. Can you see my screen?
Yes,
Yes.
Professor. Yes.
All right. So, yeah, I'm about to talk about, globally harmonized system and safety data sheet. It's something I worked on for 5 years when I was in graduate school at University of Illinois, Chicago. The global harmonized system was recently adopted. It's more than 10 years, but some countries really dragged their feet to get on board, including the US. But finally, they did. When I was working on it, it was a material safety data sheet. But when the UN took over the whole structure, now it's a safety data sheet. So basically, the main point is that you have to understand classification criteria, the labeling requirement, the training, and a pictogram that you see those pictures that really represent more than words, and so and that really helps to harmonize all safety data sheets throughout the globe. So and then we have a role of occupation health responsibility, of course, because they're the ones who have to use this, and compliance with best practices, and that's part of it. So, as I said, the MSDS was replaced by SDS now. The OSHA, when US jumped on a bandwagon, we got OSHA has the communication standard, but the EU, the European Union, have a classification, labeling, and packaging, which is CLP. And then the national variations, this is our global harmonized, what they call building blocks. They allow countries to come up with their own ways of focusing on some of the categories and classes. So it's up to countries to do this. So this is an overview of the amount of chemicals faced with. They have a NASH packet to guide anybody who would like to get the information. It has a lot of information about the MSDS now SDS. There's about 10 million chemicals, and then about 4 new are discovered every hour. Okay, though most of them are not commercialized. You can see WHO, the World Health Organization, released about 40 to 60,000 chemicals. And then US EPA is more than 80,000 chemicals. But European Union monitor only 70 substances. This is really the core of global harmonized system and SDS. And so we have a labeling guide where we have a product identification, the name, and a signal or danger warning, hazard statement, just standard phrases assigned to a hazard chemical, and then you have precautionary statements, measuring basically the way you prevent exposure to this. And then this pictogram are convey the environmental and health and environmental data. And then the supplier, because you have to have a phone number, the contact information, the supplier, the chemical. So these are some of the pictograms and meanings, and you can see that I'm sure you will somehow ran into some of these, and the first one being hazard health, carcinogen, respiratory sensitizers, and then the list really goes on until you have them all. So these pictograms, as we'll see, some are for shipping, any chemical, or transportation. So there are two types. So you can see the hazard health and flames and exclamation mark, irritant, and so they're different categories. And these are transportation pictogram. So if a truck driver, you'll be able to interpret this. You get to get certified actually. If you're driving a truck with a lot of chemicals, you got to have these pictograms. Otherwise, you won't be going along the laws. So the hazard identification, the foundation, actually, we're looking at the difference between physical and health and environmental hazards, and then when it comes to category system, the lower the greater the hazard, and then we have health hazards for clinical use, because the reason we did this is trying to make sure the clinicians and occupational health professional hygienists are really able to use this in an efficient way. Acute toxicity, we all know the lethal dose 50, and then lethal concentration 50. And chronic hazards, we rely on this pictogram. Sensitization will be another area which we look at this, and then toxicological route of entry can be inhalation, dermal, or oral. These are the list over 16 sections. Only 11 are required. You can see down here, the options are from 12, 15, the last one being the preparation date and revisions. I'm sure somewhere there is an MSDS I created with my name, but it's no longer allowed. According to the lawyer who's part of our Global Applied Prevention Center, if you write down your name, they can sue you. So now the name had to be the name of the company that you worked for. So section 11 is very important. That's where you have the toxicology information and scientific basis. Why this chemical is hurting? Because now the doctors, nurses, and hygienists say really to be able to understand this and the prognosis and exposures. And then a lot of exposure, we already know this, and the key things acute versus delayed, when it comes to this. You have symptoms will appear quickly, that's immediate, like a coughing from inheritance. Delayed, you can be exposed to some of these gases, and then the damage will show up really after a number of hours or even days. So these are there's technical terms we use, LD50 and LC50. Section number 4, the first aid, that's actionable plan, what to do. This takes the clinical information from 11 from toxicology, translate into information that can be used by first responder and immediate care providers. So then he described the first aid measures in case of inhalation, skin contact, eye injection. And then, the most important symptoms of it, it's really going back to this immediate and delayed. This directory refers to clinical findings from 11 and present in clear technical, basically using really layman terms, headache, dizziness, fatigue. And then when there's an indication, immediate medical attention and special treatment, this is the most critical part. Antidote to specific treatment and what you do, do you go for chelation for some of the agents? I happen to have in the audience Armando Chamorro, who's a certified industrial hygienist. We worked together on lead poisoning in Miami and in Kuwait. In Kuwait, he did it remotely, but I was there physically. And when we were doing our research, there was a case of basically a man was fishing with his son, and then while he was fishing, the kid was close to some of his tools. He grabbed a fishing rod and swallowed it. And then when he turns around, he saw his kids really struggling, and then immediately, oh my God, he just swallowed this stuff. And then he took him to the emergency room, and the doctor from the emergency room called me, this Nova Southwestern University, was a friend of mine, said, hey, I got the kid with who just swallow a fishing rod. And they did the test and found out he had 45 micrograms of deciliter, which is really high. Because now the CDC action standards, it's it's now 3.5. And this kid had 45. So he started the chelation process, and after 3 months, the level went down to 20. And then after 6 months, they were really below 10. You can see this was really usable in a way, because lead is one of those chemicals there's ring around because of at some point of at the end of the radioactive disintegration, it becomes stable. So it doesn't go anywhere. It can be in the soil, it can be in the water, whatever it is, it will be around forever, basically. So the critical link of occupational professionals are basically here. You're trying to link the section 1, the first aid, to the toxicology, which is 11. And then you see the section that we state the chemicals respiratory, can cause pulmonary edema. 4, then it gives you ways of dealing with this. If it's delayed, you may want to keep that person for 48 hours observation, because you never know what might happen. So then we have a section 9, which is a chemical nature, and then the rules in 7. This is provide the practical ways of dealing with this, and this is not arbitrary. Basically, there are what the practitioner need to do. The hygienists need to be able to come up with safe storage ways in some of the rooms, because you don't want to mix some of those chemicals with other. They might lead to explosion and some inflammation. Some flames, causing. You have temperature, pressure, flash points. And so section 9 data, this is the lowest temperature to which a liquid provide off enough information about And then we have boiling temperature. When you know this, and then number 7, section 7, when a chemical have a low flash point, section will mandate to store in a flammable cabinet, a very ventilated area, because you don't want any problem. And then when vapor density and ventilation, we have the density of a chemical vapor. The air have 1. And then if the vapor density is greater than 1, or this one is heavier. So around the floors, around, you'll be lingering around. That's why you got to make sure that you know this, And then solubility and cleanliness, and some of the chemicals are soluble in water. And if it's the substance is water reactive, you got to have it away from wet floors, sprinkler systems, because you don't want any problem. If a substance has lower solubility, you might recommend a material. You don't want anything to go over the water, because for the speed cleanup, as the water could spread the hazard. And then having compatible materials. This is from section 10, which is stability and activity, and 9 was instability. And then so we have to segregate some of the chemicals from incompatible material. Or storage, you have to come up with secondary containment to prevent the mixing in event of leak. And then we have this integration of GAS and SDS and work safety. As I said, clear labeling system is very important. I had an example. One of my professors, an occupational environmental physician, University of Illinois, Chicago, he was born in Chicago, but his parents were Ukrainian. He went to Ukraine to just see where his parents, grew up and basically lived, and he was trying to help them. The problem he had, all the containers didn't have any label. So he was seeing villages, he was traveling, containers really broken, spilling all kinds of chemicals. And he came back and said, I couldn't really do anything. At the time, during the Soviet Union era, they didn't want to put labels because they don't want anybody from the West to know what they use. So today, it's just a mixture of chemicals, different villages. There's no, you can really tell what's going on. And then you have electronics SDS management, and now you can do it electronically. You don't need to do what I used to do when I was doing this and back in the early 90s. And then you have emergency response and training. You got to train your workers. They have to be, and then it had to be a continuous improvement as you go along with this. So in the practice now, we have this emergency phone numbers for doctor nurses. That's in the case. And section 4, which is first aid, we talked about actionable clinical information. And 5 and 6 is a post-incident cleanup and then exposure mitigation. So in exposure management and prevention, which is 8 and 9, 8 is exposure control and PPE. You got to be able to know these hierarchy of controls. And number 10 is stability and identifying compatibility. You don't want to mix things, they might lead to problems. In medical recording and then surveillance, you have this is where we have the toxicological information. You remember the label I showed you before? These elements, this is very important. You got 6 elements: product identification, pictogram, signal statements, basically precautionary statements, and supply information just in case you need them. And I already told you the labeling had to be shipping labels or workplace labels. And then this is effective training for employees. In the US, it's required by law to really to conduct those regular training, because if they come in and ask the employees if they've been trained, you've been in big trouble, they said no. And information had to be available to show them. Now you can use a computer, but you still have to show them what to do. This is a case of a chemical spill incident in a hospital. They found out actually this was an inaccessible safety data sheet. Revealed deficiencies in hazard communication and staff safety training. Corrective safety measures were implemented, GHS compliant labeling, and then had to refresh training. And then this highlights the critical need for proactive hazard communication and emergency preparedness in a healthcare setting. The case study number 2, it's a delayed hazard. Sun killer, isocyanate to nitrogen oxide. This classifies the respiratory sensitizers, and then you got to be, they might damage the lung. You got to remove the person to the fresh air and observe them for 20 to 48 hours, as I said, because you might have signs and symptoms after a number of hours. Skin corrosion, this is case number 3, corrosion exposure, acid and base. You got to have acid cause coagulation necrosis, alkaline cause liquefaction necrosis. Section number 4 is what do? You flush with a copious water for at least several minutes, and then a best specific note, because the best really have a penetrating nature, you got to make sure you give enough water. Now let's go to happening around the globe. Who's really implementing the globally harmonized system implementing status? You can see, if you can see Peru, I think, when you look at the map, Peru is in a partial implementation, which is good. Unlike what you see in Africa and Middle East, all red and means no implementation at all. But in some countries like Colombia, you can see they're really going in, the European countries and the Russians, and they're really doing very well in that regard. So effective global harmonized implementation goes beyond compliant labor and safety data sheet. It's a dynamic system. You got to adopt at least the most applicable vision. You got to follow. UN will publish this, and then standardize the communication elements. Hazard communication, labeling, safety data sheet. Then you integrate technology. Now you can have software that we run this, and you can automate labeling process. Unlike what they did, I had to send letters along with those chemicals when sending them out. You prioritize the training. That training is very important, and then you engage the chain supply. Those contractors, the suppliers, downstream users, they have to be aware of this. And then when we're trying to compare it to this, various ILO convention recommendations, some really like C170 chemical, the classification, labeling, safety data sheets, really, go along this, but some like major industries don't have a safety data sheet. Recommendation, the same thing. You can see recommendation on 77 chemicals, they will do that, but occupational health and safety, they don't have a classification. And then again, you look at the countries, you see Peru is here next to Paraguay, Philippines. So you're doing very well. So you went, with the 11 revision of GHS, is adding a new hazard, which is basically a global warming. It's included now. And then they change around some of the sectors handling chemicals, manufacturers, transporters, and downstream. So basically, in agriculture, you get to focus on pesticides and fertilizers. And then here you're looking at how do you really, you see those 2 pictogram, one essential pictogram, acute toxicity, aquatic hazard. And then you go to construction, silica solvents and cement, you got to deal with that. And then in industry, you got to metals and chemicals. They have their own pictogram here, you get to use. And then finally, we have this advanced work here through UN. So basically, why it matters? Millions of workers that face chemical hazards. GHS and they did improve the recognition and communication and the prevention, health protection. And the core, as you saw those 6 elements, you remember? Class hazard classification, labels and pictogram, signal words, hazard statement, 16 section SDS, and then sector applications, agriculture, pesticides, and then it's a multidisciplinary. We can't do this by ourselves in our silo. We got to work as a team. Doctors, nursing, that's hygienists, safety professionals, toxicology, environmental health professionals, educators, and that's really what I wanted to deliver to you. Anybody who would like to have the presentation, where Norville can provide this to you. So the summary, the takeaways, safety and professionals, section 897, Dr. Nurse 2411, irregular compliance, you got to have obligation to update the SDS And that's all I had for today. Thank you very much.
Thank you for your excellent presentation, Professor Gazana.
Thank you. Thank you, Cynthia.
We invite all participants to prepare your question and post them in the chat. We'll have a dedicated question and answer session to the end of today's webinar. Occupational asthma is highly preventive. It continues to have a significant impact on workers' health and employment and remains an important indicator of welfare safety in Latin American. Occupational asthma is still substantially underreported. Our next speaker will share his research and experience on allergy and asthma among workers exposed to chemical hazards. It is my great pleasure to introduce Professor Mohamed Jibai. Professor Mohamed Jibai is an occupational medicine specialist and head of occupational medicine in the School of Public Health and the Department of Medicine of the University of Cape Town, recognized by the National Research Foundation as an internationally acclaimed research scientist. He leads the Occupational Allergens and Asthma Research Program in the Center for Environmental to Occupational Health Research. His research focuses in environmental risk factors and preventive strategies for occupational allergy and asthma, as well in environmental risk factor for childhood asthma with patches or exposure-response relationships involving air pollens, pollen, and fungal spores in the complex or climate change. Professor Jibai served as chair of the Environmental and Occupational Allergy Group of the European Academy of Allergy Clinical Immunology from 2019 to 2022. He has contributed to numerous international task forces, including EAACE, guidelines or environmental science in allergy disease and asthma. He also served of the editorial boards in Korean Allergy and Clinical Immunology and the African Journal of Thoracic and Critical Care Medicine. Professor Jibai, welcome. The floor is yours.
Good morning, good afternoon, and good evening to all of you. I'm going to share my presentation. Can you see my presentation?
Yes, we do. I do.
Okay.
Yes.
Okay. Okay, I'm going to be talking about allergy and asthma in workers exposed to chemicals. So there are various clinical manifestations of occupational allergies, and they range from urticaria, which is skin reactions, to rhinitis and asthma, allergic alveolitis, anaphylaxis, and contact dermatitis. I'm going to be focusing mainly on rhinitis and asthma, as this is the main theme of my presentation. So the first thing to appreciate is that asthma is characterized by reversible airway obstruction, bronchial hyperreactivity, and airway inflammation. In this particular slide, I show you what an open airway looks like, and I show you what the airway of an asthmatic person looks like. And as you can see there, the lumen is narrowed because of contraction of the muscle, inflammation, and mucus production, and this results in airway obstruction and causes breathing problems to those that are exposed to various agents. So work-related asthma is an important occupational lung disease, and as we have heard, it's underdetected and poorly managed. It is the second most common occupational lung disease in a number of developing countries. And we have two phenotypes of work-related asthma. We have asthma caused by work, which you see on the right side, and asthma exacerbated by work. The population attributable fraction for occupational asthma is about 15 to 16%, and it's slightly higher for work-exacerbated asthma. And as you can see here, we have two other categories of occupational asthma. These are the sensitizer-induced occupational asthma and irritant-induced asthma, and I will talk about that later. So why is work-related asthma so important for low and middle income countries? Well, firstly, there's rapid industrialization and globalization of the economy. So the shifts in production goes from the developed countries to the developing countries with poor regulation. There's a large informal sector. Up to 80% of workers in certain countries work in the informal sector. The working conditions are poor and they have high exposure levels, and also there's weak regulation and enforcement. Associated with that is that workers have limited healthcare access for diagnosis, and as a result, there's also scarce resources to intervene and reduce exposures, to provide appropriate treatment, and as well as compensate workers who have gotten occupational asthma. So there are studies that show that work-related asthma appears to be declining in high-income countries. But what is the burden in low and middle-income countries? It is unknown at this particular point, and it's likely to be higher. Lower and middle-income countries carry a disproportionate burden of chronic disease, including asthma, compared to high-income countries. And in the last global burden of disease study that showed that there was an increased risk of asthma deaths and disability-adjusted life years in middle-aged adults. And these middle-aged adults are generally those adults that are of working age. And the highest asthma mortality was from occupational exposures associated with low social development regions to low and middle SDI regions. So as you will see here, the slide and showing you the global map, you can see that low and middle income countries have a much higher age standardized death rates as well as disability adjusted life years. And one of the big issues that we encounter is that there's poor medical surveillance and inadequate diagnostic capacity. And this is the reason why we have under-recognition of occupational asthma. And this is because very few workplaces provide occupational health services. In LMICs, this is estimated to be 10% or less. A number of countries do not have occupational medicine professionals, and doctors have a low index of suspicion for diagnosing work-related asthma. And workers themselves underreport also because they are concerned about losing their jobs. Now, there have been various studies that have been done of asthma globally, and what is interesting to note is that symptom questionnaires appear to be the most commonly used tool for assessment of general asthma. And the same occurs for occupational asthma. And these, and also a study that we did not too long ago found that the questionnaires that were used by doctors to monitor workers for work-related asthma, most of them, at least a quarter of them, only had general asthma symptom questionnaires. And less than 50% of these questions were validated. So the instruments that we are using to look for work-related asthma are not really detecting the adverse health outcomes that we would like to document. And as you can see in the table on your right-hand side, there are also different diagnostic practice variations between low and middle income countries and high income countries, with LMICs mainly resorting to spirometry and peak flow as their main way of diagnosing workers with occupational asthma. So let's move then on to what are the main causes of occupational asthma. And there are over 600 or more agents. We've heard earlier the number of chemicals that are being introduced into the environment on an hourly basis. And over 400 of these are sensitizers, are low molecular weight sensitizers, which are generally chemicals. And they account for up to 1/3 to 50% of workers who have occupational rhinitis, and 2/3 of occupational asthma cases are associated with low molecular weight chemicals. And as you can see in the table that I presented here, the main agents that we come across are isocyanates, metals, disinfecting agents and biocides, persulfates, and other reactive dyes and acrylates. So these are the common causes of occupational asthma that are associated with low molecular weight agents. Aside from causing allergic asthma, these chemicals can also cause irritative reactions, including irritant-induced asthma, as we heard earlier with the presentation on STSs. And there are over 200 agents that have been identified to cause occupational asthma based on an irritative mechanism. And these include exposures to cleaning and disinfectant agents, paper and pulp mills, welding, biocides, construction work, firefighting associated with various exposure to chemicals, and so on. So as we can see, asthma can be caused either from an allergic reaction to a sensitizer, or can be caused by an irritant reaction to a chemical that the worker inhales. Now they have the ILO estimates that over 1 billion workers are exposed to hazardous substances, including pollutants, dust, vapors, and fumes in working environments. And just under 70 million workers are employed in chemical and related industries. This is estimated to be about 2% of the global workforce in 2023. And there are obviously various chemical handling working populations, but the ones that we've heard about earlier include agriculture, manufacturing, mining, construction, healthcare work, domestic work, and more recently, increasingly, e-waste recycling as well. As I indicated earlier, that while the incidence of asthma may be declining in the industrialized world, there are certain agents that are now coming up as being associated with an increasing incidence of asthma. And these are exposures to irritants, cleaning agents, that are coming up even in developed country settings as important causes of work-related asthma. Very important to note also is occupational rhinitis can precede occupational asthma, or it can even coexist with occupational asthma in between 25 to 45% of cases. And just to give you a flavor of the kind of the disease burden that we are talking about, is around 10% of work-related asthma cases in Europe is attributed to disinfectant and cleaning products. And between 5 and 10% are attributed to isocyanates. And then between 2 and 5% of farm operators working with pesticides have been reported to have current asthma. So this is obviously an important area and disease outcome that we need to consider. I'm not going to go into details into this, but basically the allergic mechanism that we are talking about is an immediate hypersensitivity reaction, and that is causing the sensitizer-induced asthma. And then, as I indicated, irritant-induced asthma is caused by other chemical agents, and they are thought to cause epithelial damage and oxidative stress. And this is the reason for the inflammation and the airway obstruction experienced by workers. Now, very important to also appreciate is that workers who are inhale and who are exposed to various sensitizers do not develop sensitization and allergy overnight. They need to have recurrent exposures before their body becomes sensitized to a particular agent and develops a specific IgE antibodies to that particular agent. And when the person develops these IgE antibodies, we say the person is sensitized. And should the person continue to be exposed, they then develop upper airway symptoms like rhinoconjunctivitis. And over time, if they continue to be exposed, they then develop occupational asthma. And the mainstay of management and treatment of these individuals is actually removal from exposure. This is the only way that the person is not going to be exposed to the agent that is responsible for their symptoms. So what are the main occupational risk factors then for occupational asthma? Firstly, as we heard, the route of exposure is very important. So work processes that produce vapors, fumes, and dust particulates that are easily inhaled are more likely to cause occupational allergy and asthma. There are certain chemicals such as isocyanates that also represent an alternative route for sensitization to the agent. And sometimes you may also get co-exposure of chemicals and biological agents, where chemical agents enhance the allergenicity and the sensitization potential of agents. And we have shown this with regard to spider mites in table grape farms, where we found that workers who work with pesticides were more likely to become sensitized to these outdoor mites and develop allergy and asthma. The second important risk factor is exposure to a sensitizing agent with high allergenic potential. Not all chemicals have the same sensitizing potential. And we see this just in two examples here. For example, the risk of developing occupational asthma ranges from 5% for isocyanates and up to 50% for platinum salts, indicating that platinum salts is a very potent sensitizer. And then finally, elevated dose, meaning the longer the duration and the higher the level of exposure results in an increased risk. And this we see in various studies of workers exposed to platinum salts, acid anhydrides, and isocyanates, as well as cleaning agents. The higher the exposure, the greater the risk of these workers to developing occupational asthma. It is concerning to note that there are very few occupational exposure limits for sensitizers, and the ones that have been reported are not totally protective. So you may get workers who may be exposed to below the exposure limit, who may still become sensitized and develop asthma to these very potent sensitizers. How about host risk factors for occupational allergy and asthma? The one that is commonly reported is atopy, meaning a general tendency, allergic tendency of the individual. And this has been associated with exposure to acid anhydrides and platinum salts. Also, workers who have non-specific bronchial hyperresponsiveness, meaning very twitchy airways, and studies in platinum salt exposed workers and isocyanate workers show that these workers have increased risk. And very interestingly, also workers who have an allergic contact dermatitis to certain agents can be more likely to develop occupational asthma. And a recent study was reported that showed that workers with contact dermatitis to metals, epoxy resins, and persulfates were more likely to present with occupational asthma. There have been some studies also showing that co-exposure to cigarette smoke, especially in workers working with platinum salts and acid anhydrides, posed an increased risk. And then there's also some genetic studies, and there's also studies that show that women are more likely to develop occupational asthma than men. There have been various theories why this may be so. It could be purely because of the gender distribution of work, but there are also factors such as sex hormones and epigenetic factors that may also contribute and infer risk. So how do we diagnose a person with a suspected occupational asthma from a chemical agent? Firstly, we need to take a good clinical history and, very importantly, an occupational history. And secondly, to do spirometry or to assess that the person has got airway obstruction. And we can also do that by using serial peak flow measurements to look at work-relatedness, to show that the airways are obstructed while the person is at work, and the person's peak flows improve when they are away from work, especially for extended periods of time. There are some, in some cases, you may be able to use allergy tests to look for sensitizers, especially, for example, to isocyanates and other chemicals. However, these specific IgE tests have a very low sensitivity, but a much higher specificity. So a negative test does not exclude diagnosis, but a positive test can be quite conclusive. And very rarely is a specific inhalation challenge test done. So this is just a summary. I'm not going to go through it for purposes of time. That outlines the various steps that I have mentioned to you previously. Now, how do we manage a person who has got occupational asthma? As I indicated, the most important management is to avoid and or reduce exposure to the offending agent. This is very important because persistent exposure will result in persistent symptoms. We also need to treat the patient just like any other patient with asthma. We need to assess how impaired the lungs are, and we need to assist with rehabilitation and workers' compensation. Various studies show that if you diagnose occupational asthma early, it has a very, very favorable and good prognostic feature. And also removal from the exposure is really the intervention of choice. But if you are not able to remove the person from exposure, then you should move the person to an area of low exposure, and also provide a suitable personal protective equipment and enhance monitoring to ensure that they do not develop a worsening of their symptoms. There have been a few cases of anaphylactic reactions that have occurred in the workplace setting, especially associated with drugs and vaccines. In this case, you need to ensure there's strict environmental control of these workers, and the worker needs to be provided with a written emergency management plan and an auto-injector should they develop a subsequent reaction. And finally, the optimal management of an individual with occupational asthma is to do regular follow-up medical evaluations, to assess their symptoms and lung function, to educate them on improved work practices on how to reduce exposures, to ensure that they are taking their treatment regularly, and also to support them with regard to a workers' compensation claim. I'm sure most of you are thinking about this important factor, and this is to do with prevention. Primary prevention, as we know in occupational health and safety, is the most important way in which we can reduce and remove the burden of occupational diseases, including occupational asthma. For occupational asthma, elimination and substitution of exposures has been demonstrated in certain settings. In the absence of totally protective exposure standards, we need to continually improve the work environments by reducing the exposures and using appropriate exposure control strategies. And these can vary depending on the type of work process. As I've outlined here, there are various examples that studies have demonstrated over time. Remember that respirators do not prevent occupational asthma. Respirators reduce the exposures or the exposure to sensitizers, and therefore reduces the probability of the person developing a reaction. Very importantly is to provide adequate information and counseling, especially for adolescents and new job seekers, to ensure that they are not at increased risk with certain exposures. And very importantly, the use of screening out workers who are atopic is not to be encouraged, because of the low positive predictive value of such a practice, and also it is ethically not defensible. And then finally, to ensure that you pick up these workers very early, you need to do intensive monitoring in the first 2 to 3 years, because that is studies show that this is the period when workers are more likely to present with symptoms when they are introduced into a new job. So recently we developed a novel questionnaire and algorithm to monitor workers for work-related asthma. And this is the questionnaire. It is a very simple questionnaire. It is only 2 pages, and it was developed by choosing validated questions from various studies in the literature. And it comprises 2 parts. It has a part which asks about general asthma symptoms, and a section which I show here on the right panel, which asks the work-related asthma questions. And the specificity of these symptoms increases if symptoms occur at work or on returning home, if the person, for example, has a late asthmatic reaction, and this is commonly observed with chemicals. If symptoms improve, especially for extended periods away from work, and if workers have upper airway symptoms. Now, it's also important to remember if there are no asthma symptoms, but there are upper airway symptoms, then this is also a flag and suggests that there may be increased asthma risk in the future. And if there are appropriate allergy tests, it may be possible to assess if the person is sensitized. So we also developed an algorithm which outlines how the various steps to follow if a person reports on positively on symptoms. And also we speak about referral criteria for those workers with work-related asthma symptoms and those workers with work-related ocular nasal symptoms. And very important to note is that this questionnaire is a screening and a surveillance questionnaire. It is not a diagnostic questionnaire. And therefore, if you identify workers who come up positive on this questionnaire, then they need to be referred for specialist evaluation so that they can be assessed in terms of their clinical and occupational histories and the diagnosis confirmed using objective tests. And then finally, just a few pointers on macro strategies for prevention. The global up-to-date instruments and conventions should be in line with scientific and technological advancements. As was mentioned in the previous presentation, the ILO Chemicals Convention 170 is actually comes from 1990, and there are various other conventions also. And so the ILO is embarking on a process to try and harmonize and rationalize these approaches so that they are more scientific and technologically in line with technological advancements. We also need at a country level to improve regulation and enforcement for exposure to various chemicals, and also to be able to early identify, assess, and manage chemical hazards, as Janveer has mentioned in the previous presentation. But it's very important that the control measures that we use are evidence-based and they can be objectively determined. Also, very importantly, is to monitor high-risk workers who are exposed to these hazardous chemicals by subjecting them to medical surveillance. And as we have heard, information, education, and training is essential of both workers, but also the employers and line managers of these workers. And then finally, we need to collect data through developing appropriate health surveillance systems so that we can identify trends in terms of sentinel cases and new causes of asthma as the number of chemicals that are introduced into the work processes increase day by day. So what are the main research needs with regard? I've just listed a few of them. We need to assess the impact of occupational exposures on occupational asthma, especially in the context of climate change. And this I refer to in terms of high temperatures, persistent air pollutants, fires, widespread pesticide use. And for this, we need interdisciplinary research approaches so that we can look at the issue from various angles. We also need studies of mixed exposure scenarios, as I've alluded to earlier, and also exposure studies where chemicals are both allergenic and irritant, and what would be the safe exposures that people should be could handle these chemicals with, especially with regard to widespread use of pesticides and cleaning agents that have both these properties. Very importantly, we always focus on inhalation and breathing in the chemical, but we also need to look at the skin and to see what is the source of exposure and potential sensitization through the skin for certain chemicals. And we need to develop better diagnostic approaches and methods to evaluate sensitization to various chemicals, because as I mentioned, current tests they have very low sensitivity. And then we have the issue of exposure response studies, especially for certain chemicals where the evidence is not as strong. Example, various pesticides, while we are beginning to see a lot of signals for work-related asthma symptoms, the confirmation of these in terms of objective studies are few and far between. And very importantly, we need to evaluate our interventions to see which interventions work and also which are easy to implement. And for example, with disinfectants and cleaning agents, because they're so widespread in use, we need to be able to share approaches in terms of what the best approach would be. And finally, also to look at issues of sex and gender sensitive strategies for asthma prevention, surveillance, and management in occupational settings. And thank you very much. That is all that I have to say on this for now. Thanks.
Thank you very much, Professor Mohammed, for your excellent presentation on asthma and chemicals. Invitamos a los participantes a que puedan escribir sus preguntas en el chat. Tendremos tiempo para las preguntas y respuestas al finalizar el webinar. La grabación se difundirá, contará con los subtítulos de traducción. Pasando a otro tema, vamos a hablar sobre sílice. La exposición en el Perú a sílice es un riesgo laboral grave, principalmente en minería y construcción. Viene causando enfermedades pulmonares en estos trabajadores que laboran en este sector. Por este motivo, la prevención y el control son vitales para proteger la salud de esta población. Chile ha avanzado en la lucha contra la silicosis a través de PLANESI, Plan Nacional para la Erradicación de la Silicosis, el fortalecimiento de la vigilancia médica y el desarrollo de nuevas tecnologías de control del polvo. Es por ello que en este webinar contamos con la participación del Observatorio Internacional de Pneumoconiosis. Por lo tanto, nuestro próximo expositor es el doctor Diemen Delgado García, a quien le damos la más cordial bienvenida. Bienvenido, doctor Diemen. El doctor Diemen Delgado García es médico del trabajo en el Comité de Clasificación de Enfermedades Profesionales de la Asociación Chilena de Seguridad, HS, doctor en Ciencias de la Salud Ocupacional por la Universidad de Guadalajara, profesor de la Facultad de Medicina de la Universidad de Texas Río Grande Valley en Estados Unidos, docente del Máster en Neumología Ambiental y Ocupacional de la Sociedad Española de Neumología y Cirugía del Tórax, miembro de la Asociación Latinoamericana de Tórax, miembro de la Sociedad Europea de Respirología, miembro del proyecto internacional SOFIA del Imperial College London, director ejecutivo del Observatorio Internacional Pneumoconiosis. Bienvenido, doctor Diemen, el auditorio es suyo.
Muchas gracias, doctor Rubiel. Voy a compartir la presentación. ¿Me confirma?
Sí, se ve bien, doctor.
Perfecto. Muy buenos días, buenas tardes, buenas noches. Para mí es un placer la invitación realizada por ICOH. En primer lugar, quería felicitar al doctor Javier Gassana por esa introducción respecto a la organización y a los registros a nivel global de estos productos químicos en industria que pueden provocar muchos efectos a nivel de la salud de los trabajadores. Y creo que estamos alineados también con el Observatorio Internacional de Pneumoconiosis en obtener, ¿cierto?, también un registro en cuanto a los polvos neumoconiósicos y los efectos que pueden provocar a la salud de los trabajadores a nivel global. También quería felicitar al doctor Mohamed Yebli en respecto a su artículo publicado y a su énfasis, ¿cierto?, del área de la profundización en lo que es el asma ocupacional, que yo creo que ahí hay una gran debilidad en cuanto a las personas que nos dedicamos a la medicina del trabajo y a las personas que se dedican a la parte clínica en el ámbito privado, que muchas de las veces no hacen la pregunta clave y precisa si ese trabajador dónde trabaja y a qué está expuesto, porque fácilmente uno, identificando, ¿cierto?, que el asma es de origen ocupacional, fácilmente uno puede retirar a ese trabajador, a esa gente, y puede sanarse sin necesidad de tratamiento prolongado por varios años. Bueno, al tema que nos convoca y que quiero precisar es el título de esta presentación. Porque cuando uno habla de neumoconiosis, uno diría, una neumoconiosis se detecta a través de una radiografía de tórax con una técnica OIT. Pero si ustedes ven el título, acá habla de un estudio histopatológico para poder detectar o hacer un diagnóstico diferencial. Entonces, cuando uno habla de un estudio histopatológico, uno diría, pero ¿por qué el doctor Delgado está hablando de un estudio de biopsia y no de una radiografía, que es el método de oro para poder detectar o descartar una patología por polvo pneumoconiógeno? Bueno, y aquí les voy a presentar un- una breve introducción de lo que son las neumoconiosis, que depende de cada país, de cómo se lo aborde. En los Estados Unidos se habla que es la presencia de polvo, ¿cierto?, a nivel ocupacional. En la Unión Europea, en este caso en los Estados Unidos, hablan específicamente en lo que es Gran Bretaña, que son polvos que pueden provocar algún tipo de trastorno a nivel pulmonar. Y en China hablan sobre una neumoconiosis que puede provocar fibrosis pulmonar, y yo me adhiero a esa postura, porque cuando uno habla de neumoconiosis, uno habla de que es una enfermedad que es asintomática y que muchas de las veces, al retirar a esa persona del área expuesta, no va a presentar ningún desarrollo de síntomas o ningún desarrollo de patología o alteraciones. Pero sin embargo, la neumoconiosis puede provocar una fibrosis pulmonar, y yo creo que el término de que estos polvos pueden provocar una fibrosis es muy atingente, y que debe de ser considerada desde el punto de vista de las empresas a nivel global, de que estos polvos pueden provocar fibrosis pulmonar. Ahora, no todos los polvos tienen características de una fibrosis pulmonar. En este caso voy a mencionar las que sí hay evidencia de que puede provocar una fibrosis pulmonar, y que también existe una brecha inmensa a nivel global, ya que muchas veces estas fibrosis pulmonar suelen asociarse a fibrosis pulmonar idiopática o a fibrosis pulmonar inducidas por factores colágenos o factores tipo inmunológicos o reumatológicos, y se lo puede encasillar y se lo puede llevar hacia esa dimensión. Sin embargo, la neumoconiosis puede provocar fibrosis, especialmente en los siguientes temas, como por ejemplo una silicosis, las neumoconiosis de carbón, la abestosis, las monoconiosis de metales pesados, la luminosis, la talcosis y estos silicatos mixtos, ¿cierto? Porque cuando uno habla de silicosis hay que estar muy atento, porque no solamente es el polvo sílice la que puede provocar esta patología, sino que muchas veces vienen metales combinados, ¿cierto? Metales combinados, y que pueden provocar ya una silicosis de tipo más agresiva. Y tenemos también las neumoconiosis que tienen una limitación o poca probabilidad de una fibrosis. Por ejemplo, tenemos la siderosis, la estañosis, la varitosis, ¿cierto? Y que tienen una potencial mejora o patología estacionaria, ¿cierto?, de las imágenes radiológicas, pero que no inducen a la fibrosis, y que muchas veces en el tiempo estos pueden desaparecer o pueden quedar cicatrices mínimas sin una evolución a posterior. Y también tenemos la silicosis inmunológicos o granulomatosis, por ejemplo, la beririosis, que puede provocar una enfermedad de granulomatosis inmune, y también los metales pesados a través de una margen, ¿cierto?, de tipo inflamatorio. ¿Y cuáles son las características radiológicas, ¿cierto?, o imanológicas de la neumoconiosis? Tenemos acá el principal, o lo que más se conoce a nivel global, lo de la silicosis. Observamos que esta provoca a nivel pulmonar una evolución eh, agresiva en muy pocos pasos, pero más bien una evolución más simple en la mayoría de los casos, especialmente porque en los últimos 30 años ya existen medidas más tecnificadas de protección respiratoria, modificación y un sistema de tecnología industrial que ha permitido, especialmente en nuestro país, en Chile, una disminución de manera importante de los nuevos casos de silicosis comparado con otros países, por ejemplo Perú o por ejemplo Bolivia o México, que no existe todavía una industrialización tecnificada. Yo creo que el modelo chileno es un modelo que se puede replicar a países de la región y también y también a nivel global. Algo muy interesante que quiero dejar plasmado es que si ustedes observan esta imagen donde existe fibras colágenas que envuelven, ¿cierto?, a la partícula de sílice, es que en la biopsia o en el estudio histopatológico esto se muestra con cristales birrefringentes. Esa palabra quiero que la mantengan ustedes en su mente durante estos 20 minutos que me dieron, porque es muy vital para el caso que vamos a observar, el cuadro clínico que vamos a observar, ya que la sílice provoca luz polarizada, cristales birrefringentes. Este es un caso de talcosis, que también es una neumoconiosis. Como ustedes observan aquí en la biopsia, existen las moléculas, ¿cierto?, de aluminio, y también existen cristales birrefringentes. Como ustedes observan, esta imagen es muy parecida a la anterior de lo que es lo que es la sílice, y por lo tanto es muy importante también la historia ocupacional que uno tenga a la mano para poder descifrar, ¿cierto?, la exposición que puede provocar estas reacciones, como observamos en esta imagen sagital de un tarjetura donde se observan imágenes redondas que compatibles, ¿cierto?, con talcosis, pero que es muy similar casi a la mayoría de neumoconiosis. En este caso tenemos una neumoconiosis mixta, donde existen metales, donde existen silicatos, donde en la biopsia se observa cristales birrefringentes, de alta birrefringencia, lo que nos puede, ¿cierto?, llevar que esta persona esté expuesto a partículas, en este caso, metálicas. En este caso, es una neumoconiosis por carbón o mineros de carbón, donde uno observa estas máculas, ¿cierto? Y este enfisema a nivel de intersticio. Y lo característico de esta neumoconiosis es que muchas veces uno escucha de que las neumoconiosis siempre están asociadas a opacidades redondas, y excepto la festosis está asociada a opacidades irregulares. Estoy hablando de la clasificación de la técnica de Tora-Goité, pero la característica del carbón, de la partícula de carbón, es que aparte de opacidad redonda, puede provocar opacidades irregulares, y esta es sumamente agresiva, provocando una fibrosis pulmonar muy importante. Los que nos dedicamos al tema de la neumoconiosis sabemos que la abestosis predomina las alteraciones intersticiales a nivel de bases pulmonares, y los clínicos que nos dedicamos también a la neumología sabemos que las alteraciones o las enfermedades de tipo intersticial pulmonar, como la fibrosis pulmonar, también inician a nivel de las bases pulmonares. Así que hay que tener mucha atención y mucho ojo cuando decidimos, ¿cierto?, eh, el diagnóstico clínico y el tratamiento. Tenemos que abordarlo de manera muy importante. Y aquí es importante también aclarar que no solamente el médico de salud ocupacional debe, ¿cierto?, de especializarse en estos temas, sino que también debe haber un equipo multidisciplinario que acompañe al médico de salud ocupacional, el neumólogo, el histopatólogo, el radiólogo, ¿ok? Ya que en muchos campos de las sociedades científicas de neumología solamente hablan del reumatólogo, del radiólogo, del inmunólogo, pero no hablan del médico del trabajo. Entonces, yo creo que este espacio es importante para poder sensibilizar a todo lo que nos dedicamos a la parte pulmonar. Esta es una imagen de fibras de asbestos, como ustedes observan, y estas fibras de asbestos, es muy importante acá hacer una pausa, porque siempre cuando hablamos de fibras de asbesto hablamos de asbestosis, y la asbestosis es una enfermedad ocupacional que afecta el intersticio, pero cuando hay dosis muy pequeñas o cuando hay exposiciones muy mínimas, no va al intersticio, sino que por un fenómeno de gradiente de presión, estas emigran hacia la pleura y pueden provocar estas placas pleurales que se observan acá en una imagen de mediastino. eh, Esta placa pleural que están calcificadas a nivel paravertebral o a nivel de tórax anterior. Y entonces es muy importante aclarar que muchas veces estas placas pleurales o estos engrosamientos pleurales sin abestosis, sin afectación pulmonar, puede ser un indicador a posterior de que esa persona pueda formar un mesotelioma. Entonces, puede haber simplemente placas pleurales y engrosamiento pleural, o puede haber solamente asbestosis cuando es la afectación a nivel de intersticio, o puede haber mixta, ambas, tanto afectación pleural como afectación del intersticio. Otra pneumoconiosis es provocada por el berilio, ¿cierto? Que provoca un cuadro crónico de beriliosis. Se observan acá algunas, en el corte sagital, algunas opacidades redondas o opacidades nodulares, que lo diría así un radiólogo. Y aquí lo interesante es que muchas veces esta se confunde con una enfermedad que se llama sarcoidosis, que todavía no se genera cuál es el origen, pero que hay mucha asociación y mucha literatura que estas sarcoidosis se puede asociar a una silicosis, pero en el caso de la beriliosis es muy similar lo que es la imagen que se puede observar, pero para eso tenemos una herramienta que es la evaluación de los linfocitos de proliferación de berilio, que se puede hacer a través de un test a nivel sanguíneo, y ahí si esto es positivo ya sabemos entonces que fácilmente se puede considerar una neumoconiosis por berilio. Por lo tanto, existe la tecnología, existe el conocimiento. Lo que ocurre en nuestros países es que no tenemos la capacidad eh, financiera para implementar ciertos laboratorios, pero a nivel global existen apoyos que uno puede fácilmente poder conversar y poder transferir conocimiento para poder llegar a un buen diagnóstico. Tenemos las neumoconiosis por aluminosis. Aquí ustedes observan este examen histopatológico aglomerado, ¿cierto? Lo que es el aluminio. Nuevamente acá observamos una radiografía de tórax con imágenes opacidades redondas a nivel superior, y observamos acá el hilio que está ya ascendiendo. Estamos hablando ya que existe una fibrosis porque existe una retracción del hilo pulmonar hacia la parte superior, y fácilmente nos podemos confundir nuevamente con una silicosis o alguna otra patología. Las pneumoconiosis por metales pesados, igualmente observamos acá estas imágenes que muchas veces son mixtas y están combinadas, entre ellos el 90% por tuxúgeno, el 10% por cobalto, y también se ha observado níquel y titanio. Y aquí observamos en esta radiografía de tórax clínico un conglomerado, ¿cierto? Opacidades redondas, que es una retracción, ¿cierto? Y como dijimos anteriormente, que provoca este tipo de fibrosis pulmonar. Igualmente, en un corte sagital se observa estas imágenes intersticiales que fácilmente uno la puede confundir con una enfermedad intersticial de tipo inmunológica o tipo colágena, o también alguna patología por drogas o medicamentos que también pueden provocar estos tipos de manifestaciones radiológicas. Otro tipo de neumoconiosis son las siderosis, que provocado por hierro, y ya mencioné anteriormente que muchas veces este tipo de siderosis, al no continuar la exposición, al ser retirado, estas no evolucionan en el tiempo, es decir, no provocan fibrosis, y que muchas veces estas pueden desaparecer o puede quedar como un estigma a nivel pulmonar. Algo importante que recalcar es que muchas veces estos metales, en este caso la acidosis, puede estar combinada por otros metales, como por ejemplo, en este caso el bario, que provoca la varitosis, o la estenosis, que también puede provocar, pero que es, como dije anteriormente, es un elemento más benigno y que no debería provocar una fibrosis pulmonar en el tiempo. Ahora les voy a presentar un caso clínico que es el que genera, ¿cierto? Esta presentación. Gracias por el espacio que nos brinda la ICOH. Y es un paciente de 36 años de edad, con una historia de 18 años de tabaquismo, 3 años, trabaja en una minería subterránea, y hace 15 años trabaja en general en una minera realizando tareas de perforación. Si uno observa esta radiografía de tórax, que es una radiografía estándar de tórax, no es una radiografía con técnica OIT, eh, por el cual este paciente consulta por disnea, uno fácilmente se da cuenta que es una radiografía que no es normal, es una radiografía que está completamente alterada, y que si uno hiciera el esfuerzo de interpretarla, uno observa estas opacidades redondas que predominan a nivel medio y a nivel basal, y no a nivel superior. Entonces, estamos frente a la presencia de una radiografía alterada, la cual se realizó el 12 de marzo del año 2025 en el momento de admisión a un hospital. Eh, entonces, este paciente ingresa con dificultad respiratoria, con disnea, con dolor torácico. Por ese cuadro clínico inicial se considera que probablemente sea una embolia pulmonar, ¿cierto? Una tromboembolia pulmonar. Se realiza un TAC de tora, donde en las partes basales se observa un conglomerado, ¿cierto? Un relleno alveolar que probablemente está ocasionado por un cuadro agudo de tipo biológico. Se le hace exámenes de sangre donde tenemos una leucocitosis, ¿cierto? 11.540. Tenemos un dímero D, está en 555 nanogramos ml, que también nos hace sospechar de esta posible tromboembolia pulmonar. Eh, mm, eh, Tenemos un examen de VIH que es negativo y un panel respiratorio negativo. Es decir, en este momento con este panel respiratorio viral, uno pudiese descartar, ¿cierto?, que la gente pudiese ser un virus y pudiese ser más bien una bacteria por el cuadro clínico que el cual consulta. El planteamiento entonces de los diagnósticos diferenciales es de una neumonía comunitaria vivasal, como se observa en este corte del escáner de tórax, una fibrosis intersticial que debe ser investigada, un tabaquismo crónico y una posibilidad de una enfermedad pulmonar obstructiva crónica. Estos son los cortes de tipo torácico, coronales, que uno ahí observa que el pulmón completamente está alterado, específicamente en las bases pulmonares a nivel parietal. Este es un control ya el 30 de marzo, es decir, en 15 días, en el cual uno observa que existe una mejora importante a nivel de intersticio pulmonar, en el cual el paciente recibió antibiótico, amoxicilina más azul clavulánico, o antiinflamatorios como prednisona, y inhaladores orales, fluticasona salmeterol y bromuro de hipatropio, y por estas características, ¿cierto?, clínicas de una alteración importante, evidente, que posiblemente sea una neumonía, pero que a su vez se encontró algunas alteraciones a nivel de intersticio pulmonar, se consideró realizar una biopsia transbronquial. Luego, en abril del año 2025, por ser un trabajador, ¿cierto? Un trabajador minero y que está vigilado bajo un programa de vigilancia epidemiológica, un tamizaje, porque está expuesto a polvos neumoconiógenos, se le realiza una radiografía de tórax con técnica OIT, donde el médico que interpretó esta radiografía consideró que existían opacidades redondas, categoría QQ, en una profusión 2,2. Pero si uno hace el esfuerzo nuevamente de poder interpretar esta radiografía, uno puede observar que en realidad existen estas opacidades redondas, pero siempre predominan en lo que es la parte media y la parte basal y no tanto en la parte superior. Y es casi similar, ¿cierto?, a la radiografía que vimos, en la primera radiografía que vimos, a pesar que no era la técnica adecuada, pero es muy parecida. Entonces vemos que en abril de 2025 se consideró que había una silicosis con una profusión 2,2 QQ. En este mismo abril se realizó una espirometría, en la cual se observa que no hay ninguna alteración espirométrica en este paciente. Probablemente no hubo ninguna alteración a nivel bronquial, por lo tanto no hubo ninguna consecuencia sobre esto. Esto es para que ustedes observen cómo en abril el 30 de abril de 2025 se observa completamente limpio las bases pulmonares, es decir, que el factor biológico, aparentemente una bacteria, ¿cierto? Ya tuvo una resolución, pero sin embargo existen estas imágenes redondas, nodulares, que persisten a nivel de todo el pulmón. Ya sabemos que la silicosis más bien es de tipo apical en lóbulos superiores, y sabemos que también la abestosis es a nivel basal, pero más bien de opacidades irregulares, mientras que acá uno observa opacidades redondas en casi todo el territorio del territorio pulmonar. Algo interesante que hay acá es que la silicosis se caracteriza siempre por estar como agrupada a nivel de a nivel de las cisuras, lo que se llama la distribución linfática, y este no es el caso, pero sí observamos imágenes redondas que nos impulsan a que esta persona no está completamente sana, sino que tiene un problema de tipo pulmonar, que ya sabemos que ya fue tratada lo que es la neumonía. Este es de tipo coronal. Vemos muchas opacidades redondas distribuidas en todo el territorio pulmonar. Y bueno, este caso, como dije anteriormente, ¿por qué biopsia? Porque no en todos los países se hacen biopsias. Muy poquitos países hacen biopsias para realizar un diagnóstico médico legal, como por ejemplo acá en América, Colombia. Pero el resto de los países, el diagnóstico definitivo es a través de una radiografía de tórax con técnica UIT. En este caso, se realizaron dos biopsias, el 12 de junio y el 29 de julio del año 2025. La del 12 de junio del año 2025, la condición de entrada para hacer este estudio fue que había una enfermedad intersticial y que habría que hacer un diagnóstico diferencial entre silicosis y sarcoidosis. Eh, lo que llama la atención acá es que a la luz polarizada no había refringencia. Entonces, ese es el primer punto. No hay refringencia, y al no haber refringencia, uno ya descartaría, ¿cierto?, la presencia de silicosis u otros metales que provocan fibrosis. El 29 de julio se realiza una segunda biopsia, y igualmente acá más bien como que se le da la intencionalidad, ¿cierto? De que esto está provocado, ¿cierto? Por carbón, pero más bien todos sabemos que la gran población a nivel global fuma, ¿cierto? Y por lo tanto es un factor confundente cuando uno habla de carbón. eh, y y algo importante es que acá también en esta biopsia también no hay birrefringencia, por lo tanto uno lo podía descartar que es una silicosis o por metales pesados u otros agentes fibrogénicos, pero llama la atención de que mencionan que es una neumoconiosis, ¿cierto? Una neumoconiosis, pero sin silicosis. Llama mucho la atención, estoy hablando del punto de vista clínico, ¿cierto? No ocupacional, sino clínico, del histopatólogo, cómo enfrenta esta problemática en cuanto a cómo descifran, ¿cierto? Esta competencia en cuanto al conocimiento de las neumoconiosis. Y el 14 de agosto de 2025, un médico neumólogo o bronco pulmonar emite ya una definición del cuadro global de este paciente del cual estamos estudiando, donde él menciona que esta persona, ¿cierto?, tuvo un problema a nivel intersticial que probablemente era una silicosis, pero se descartó porque hubo una respuesta adecuada al tratamiento, pero también menciona que los estudios que se realizaron, ¿cierto?, consideran que estamos frente a la presencia de un paciente con una neumoconiosis sin silicosis, ¿ya? Por lo tanto, por lo tanto, ratifica que el nombre, ¿cierto?, de la presentación es adecuada, ¿cierto?, a este caso clínico, ya que estamos frente a la presencia, ¿cierto?, de un estudio histopatológico de una neumoconiosis sin silicosis, que uno le genera algunos ciertos bemoles, ¿cierto?, en cuanto al pensamiento y en cuanto a afrontar este cuadro clínico. Resumiendo, entonces, tenemos a un trabajador minero, ¿cierto? Con 18 años de exposición a sílice cristalina. Eso es lo que nos registra la historia ocupacional, ¿cierto? Es un trabajador expuesto a sílice cristalina, donde tiene muchas labores, perforación, operación de maquinaria pesada. Es decir, esta persona está expuesta, en este caso, a la gente que es la sílice cristalina. Algo muy interesante es que esta persona en los registros del año 2022 al 2025 no hay documentos o no existe documentación de que esta persona esté expuesto a, a beridio, ¿cierto? O a otros metales. Siempre mencionan que está expuesto a sílice. Por lo tanto, es importante una reflexión de que las personas que están a cargo de hacer una buena historia ocupacional, ya sean los higienistas o la parte indígena, es importante, ¿cierto?, que las áreas de trabajo identifiquen cuál es el agente en el cual se hace un tamizaje, ¿cierto?, a través de una radiografía de tórax para poder tener una dualidad respecto a qué enfocarse en el diagnóstico diferencial. Entonces, estamos frente a la presencia de un trabajador que está expuesto a sílice, que no estuvo expuesto a asbesto y que tampoco confirman que ha estado expuesto a berilio. Esto es una comparación de radiografías cuando este trabajador tenía 33 años. Esto fue en septiembre de 2022. Este es un tamizaje, como él está expuesto a polvo sílice, este es un tamizaje donde si uno hace un esfuerzo, uno observa opacidades redondas a nivel medio e inferior. Esta fue considerada una profusión 0,0, ¿ya? eh, eh, llama mucho la atención porque se observan fácilmente imágenes redondas, medias y basales. Y esta es la radiografía con la cual el paciente ingresa a la unidad de cuidado intensivo, al hospital, donde aquí se observa con mayor claridad estas imágenes que también se observan en el año 2000, en el año 2022, y que en el control, ahora, después del cuadro de neumonía, en abril, ¿cierto? Se hace una radiografía de tamizaje y ya le aplican el 2,2. Si uno compara esta radiografía del 2025 con la de 2022, yo creo que no hay ningún tipo de duda de que ambas están alteradas y que posiblemente la que está más alterada es la del año 2022. Entonces ahí es la pregunta, ¿a qué nos estamos enfrentando? Bueno, este es un control también de una vista sagital donde observamos cómo evoluciona la neumonía a un estado estable, ¿cierto? Desde el punto de vista de su enfermedad biológica, pero sin embargo permanecen estas imágenes redondas a nivel del intersticio pulmonar. Igualmente, esta es una imagen coronal para que ustedes observen cómo evoluciona rápidamente, pero permanecen estas imágenes opacidades redondas a nivel del intersticio pulmonar. Ahora, ¿qué patologías pueden simular una neumoconiosis? Existen muchas patologías que pueden simular una neumoconiosis. Está la sarcoidosis, la tuberculosis, la neumonitis por hipersensibilidad, la diseminación de cáncer a nivel pulmonar, la distancia, la amiloidosis, la carcinomatosis ligamentosas, lo que son la metástasis de carbón, las granulomatosis por inmunodeficiencia y la histoplasmosis. Es decir, es una gran cantidad de patología en el cual el médico se ve enfrentado a los cuadros clínicos. Por lo tanto, estos tipos de espacios que nos da la ICO nos da fortaleza, ¿cierto? Para poder transmitir que no es fácil, ¿cierto? Detectar una neumoconiosis, que no es fácil descartar una neumoconiosis, pero sí hay que hacer el esfuerzo de la transmisión de conocimiento. Y nos hacemos una pregunta para discusión. En este caso, estamos frente a qué patología. Por ejemplo, si hablamos de sarcoidosis, que se puede confundir con una beriliosis, como se mencionó anteriormente, la distribución de las opacidades redondas o opacidades nodulares, ¿cierto? Ustedes observan que afecta a nivel subpleural y no afecta lo que es las cisuras. Por lo tanto, la característica de una silicosis es al contrario, se agrupan, se hermanan, están a nivel de la parte cisural, de la parte perilinfática. En este caso, la histopatología descarta porque no hay birrefringencia. Entonces, nos da la tranquilidad de que no estamos frente al caso de una silicosis. Esta sarcoidosis tiene una distribución linfática muy similar a la silicosis, pero la histopatología, que es el diagnóstico de oro, que desde el punto de vista médico, eh, filosófico y nosológico, el que tiene mayor cercanía a la verdad de que a qué cuadro clínico estamos enfrentando es el histopatólogo. En este caso, el histopatólogo dice, señores, no hay cristal birrefringente. Y las características de la silicosis y los metales pesados es la birrefringencia. Ahora, ¿estaremos frente a una neumonitis por hipersensibilidad? Entonces, vemos que este paciente, ¿cierto?, tiene una distribución centrobuliar donde respeta la cisura, respeta el subpleural, entonces eh, uno se pudiese, ¿cierto?, eh, adherir a que posiblemente este cuadro clínico del paciente presentado posiblemente es una neumonitis por hipersensibilidad. Neumonitis por hipersensibilidad que puede ser provocada por un sinnúmero de factores, no solamente en el trabajo, sino también en el hogar. Entonces, es importante también en el interrogatorio, en la anamnesis, siempre preguntar al trabajador, ¿usted dónde trabaja? ¿Cierto? ¿A qué agente está expuesto? En su casa existen algunos agentes que también pueden provocar estos problemas de sintomatología respiratorias, criadero de aves, moho, em, algún tipo de actividad física donde ellos posiblemente transiten. Entonces, es importante considerar todos estos cuadros del origen. Igualmente, cuando el histopatólogo habla de la presencia de una neumoconiosis, sin silicosis, también uno pudiese decir, entonces, es una siderosis, es una beriliosis, es una aluminosis o es una talcosis. Entonces, son diagnósticos diferenciales que hay que hacerlo y hay que hacerlo de manera adecuada, desde el punto de vista ético, ya que nos enfrentamos, ¿cierto?, a un paciente que vamos a definir su destino, si esto fue un cuadro de neumonía comunitaria o es un cuadro asociado al trabajo o asociado a actividades extralaborales. Según los estudios que realizamos, de acuerdo a las mesas de trabajo que realizamos por este caso, posiblemente estemos frente a la presencia de una neumonitis por hipersensibilidad desde el punto de vista radiológico, caracterizado lógicamente por imágenes centrolobuliares características y que posiblemente las arrastre desde muchos años, como ya lo vimos en las radiografías de tórax. Para para finalizar, es importante indicar que el Observatorio Internacional de Pneumoconiosis está haciendo todos los esfuerzos eh, posibles para generar una base de datos. En cada uno de los países tenemos adheridos 27 países, tanto América, Europa, África y Australia, donde queremos a futuro tener un trabajo de hermandad, ¿cierto? Con la ICOH, donde podamos, ¿cierto? Hacer fuerza para poder eh, educar, transmitir conocimiento, no solamente a los médicos, sino también a las empresas, a los trabajadores, a los sindicatos, que es un bien común el conocimiento, y yo creo que eh, el doctor Fernando Peñafiel Castillo, que es el secretario general del Observatorio Internacional de Pneumoconiosis, nos va a dar más luces de cómo enfrentar, ¿cierto?, esta patología que es emergente actualmente tanto en España como en Australia, como en California, y que hace mucho tiempo debió ya erradicarse y no se ha logrado. Por lo tanto, la justificación de los objetivos del Observatorio Internacional de Pneumoconiosis son tangibles. Muchas gracias y estoy atento a las preguntas a futuro.
Muchas gracias, doctor Diemen, por su excelente presentación. Definitivamente falta todavía ampliar la forma como hacer esta vigilancia por exposición a sílice y otros materiales particulados. Definitivamente el diagnóstico en nuestro país requiere fortalecimiento. Vemos las estadísticas todavía que aún subregistro, ¿no? El subregistro todavía prevalece, ¿no? En ese sentido, le agradecemos por esta participación. Muchas gracias, doctor Dieme. Para conocer más acerca de los avances en vigilancia de la salud de los trabajadores y con el objetivo de la erradicación de la silicosis, Y bueno, y para conocer un poco las experiencias, un poco más de las experiencias desde Chile, a continuación tenemos el honor de dar la bienvenida al doctor Fernando Peñafiel. Bienvenido, doctor. El doctor Fernando Peñafiel es médico especialista en salud ocupacional y salud pública y director médico nacional del Centro Médico del Trabajador de Chile. Cuenta con formación de posgrado en salud ocupacional por la Universidad de Chile y un MBA con especialización en salud por la Universidad Andrés Bello. Es lector certificado por NIOSH, categoría B, y posee experiencia en la clasificación internacional de radiografías de pneumoconiosis de la OIT, ex médico ocupacional en operaciones mineras de gran altitud, miembro del Comité de Revisión Técnica para Acuerdo de Estandarización de Compatibilidad de Salud de CODELCO, miembro de la Sociedad Chilena de Medicina Ocupacional, la Asociación Latinoamericana del Tórax y la Sociedad Europea del Respiratorio, secretario general del Observatorio Internacional de Pneumoconiosis. Doctor Fernando, bienvenido, el auditorio es suyo.
Muchas gracias, Dr. Uriel Yankee. I'm going to start to share my presentation. Can you please tell me if I am correct? Is in the presentation mode? Yes, can you see?
Yep, we can see it.
Thank you. So, good morning, good afternoon, good evening, colleagues. Thank you very much to ICOH, to the Scientific Committee on Occupational Medicine, the Scientific Committee on Occupational Health in the Chemical Industry, and the ICOH National Secretary of Peru for this invitation. My name is Fernando Peñafiel Castillo, and I represent the International Pneumoconiosis Observatory. Today, I would like to present the Chilean model. No, I'm not. Yes. Today, I would like to present the Chilean model for managing occupational exposure to silica and inorganic dust. I will then compare this experience with recent developments in Spain, Australia, China, India, and South Africa. My main message is simple. Silicosis is preventable, but preventions require much more than performing chest X-rays. It requires a complete system connecting exposure control, occupational medical surveillance, diagnostic quality, information system, and social protection. So, why begin in Chile? Well, Chile is one of the world's leading mining countries and holds approximately 77% of global copper reserves. Mining is therefore not a marginal economic activity. It's part of our national history, it's part of our identity. However, silica exposure in Chile is not limited to large copper mines only. It is also present in construction, quarries, aggregate plants, foundries, ceramics, dental laboratories, demolition, stone processing, industrial maintenance, and small workshops. One important Chilean study evaluated 132 companies across 31 economic sectors. It found that 35% of the sector assessed and 33% of the air samples exceed the occupational exposure limits. The researchers estimated that approximately 347,000 workers, or 50.4% of the employed workforce at that time, had a high probability of occupational silica exposure. This study changed the national understanding of this disease, of the silicosis. It was no longer seen only as a disease linked to underground miners, but as a multi-sectorial public health problem. So in Chile, the geography of silica exposure is much broader than the geography of mining. So we got Planesi, that the main national response is Planesi, is the national plan for the eradication of silicosis, covering the period from 2009 and 2030. The political commitment began in 2007 when the Ministries of Health and Labor agreed to participate in the Global Silicosis Elimination Initiative promoted by the World Health Organization and the International Labor Organization. Planesi has 5 major objectives. First, to reduce and control occupational silica exposure. Second, to reduce the incidence and the prevalence of silicosis. Third, to improve early diagnosis, medical follow-up, compensations, and social support. Fourth, to strengthen the information system. And fifth, to implement the plan through tripartite participation involving governments, employers, workers, and occupational insurance organizations. This is important because Plan C is not simply a medical screening program. It is a national governance model. In 2026, the Chilean government reaffirmed Plan C as a priority and established a target to increase workplace and health surveillance programs from 50% of identified companies in 2024 to 75% in 2028. The Chilean model distributes responsibilities across several institutions, like all the countries, of course. The Ministry of Health develops the public health policy and national surveillance protocols. The Ministry of Labor and Social Welfare integrates silicosis prevention into labor and social security policy. The Superintendence of Social Security, known as SUCESO, supervise occupational insurance administrators and manage National Information System. The Institute of Public Health, or ISP, provides technical reference, laboratory capacity, methodological development, and quality assurance. Regional health authorities and the Labor Directorate conduct inspection and enforcement. Occupational insurance administrators perform workplace assessment, prescribe preventive measures, evaluate exposed workers, and provide medical and economic benefits of the law 16744. So employers they have the responsibility of identify the hazard and exposed workers, while the workers and their representatives for the union, for example, participate through national and regional tripartite structures. The strength of this architecture is that no single institution is expected to manage the entire pathway alone. The weakness, for other hand, is that coordination and information transfer must work consistently across all these institutions. So the Chilean Institute of Public Health, or ISP, plays a particularly important role. Its occupational health department is currently designed as the Pan American Health Organization and the World Health Organization collaborating center for occupational health. Its term of reference includes supporting programs on occupational cancer, silica, asbestos-related disease, healthy workplaces, high-risk sector, mining, and work at altitude. This international designation as referent is very relevant because the ISP is not simply a national regulatory laboratory. It participates in the production and transfer of knowledge across Latin America. Pan American Health Organization reports that the ISP has led and coordinated regional work supporting the initiative for the elimination of silicosis in the Americas. It has contributed to policy review, technical tools, training, and the development of exposure surveillance initiatives. Within Chile, the ISP has been central to the development of qualitative exposure methods, analytical methods, radiological quality standards, occupational health guidelines, and external quality assessment programs. This creates an important conception between policy and technical implementation. So Plan C was the backbone and provides the national strategy to affront this mass of workers that are exposed. And the ISP, for other hands, tried to provide much of the technical support needed to make this strategy operational. These slides shows how Chile translates a regulatory exposure limit into a value that reflects actual mining conditions. Under the Supreme Decree 594 and the National Silica Surveillance Protocol, the occupational exposure limit for respirable quartz is 0.08 milligrams per cubic meter. For cristobalite and tridamite, the limit is 0.04 milligrams per cubic meter. However, these values cannot always be applied directly. Many Chilean mining operations are located at high altitude and use extended shift, often lasting 12 hours. Both factors requires corrections, the altitude and the extended shift. So in this example, The mine is located at approximately 3,000 meters above the sea level, where the local atmospheric pressure is 525 millimeters of mercury. The altitude factor is therefore calculated as 525 divided by 760, giving a value of 0.69. When we multiply the base quartz limit of 0.08 by this altitude factor, the adjusted comparison value decreased to approximately 0.055 milligrams per cubic meter. If the worker also performs a 12-hour shift and a shift factor of 0.5 is applied, the final corrected value decreases further to 0.0276 milligrams per cubic meter. The practical message here is that a measured concentration may appear acceptable when compared with the uncorrected limit, but become unacceptable after altitude and shift duration are considered. The first objective must always be to prevent dust from reaching the worker's breathing zone. Chile's mining authority, Cernageomin, has issued methodological guidance for underground mine ventilation projects. The ventilation system must consider airflow requirements, pressure losses, fan capacity, ducting, flow direction, diesel equipment, blasting gases, temperature, and suspended dust. The central principle is that ventilation should be designed as a part of the mining project, not added later as a reaction to excessive exposure. General ventilation must also be combined with local control. Wet drilling, water-assisted cutting, local exhaust ventilation, process enclosure, pressurized cabins, remote operations, ideally, but too expensive, road watering, filter maintenance, and safe cleaning methods. This is important to remember that dry sweeping or the use of compressed air can resuspend fine particles and generate a second exposure episode after the original task has finished. So respirators are important, but they are the final layer of protection. A respiratory protection program cannot compensate for a poorly designed ventilation system. ECRES. So large mine may have very big departments with occupational hygienists, laboratories, real-time monitoring, and engineering departments. But small companies do not. To address this gap, Chile developed ECRES. ECRES is the Qualitative Silica Exposure Risk Assessment Method. ECRES was designed as a practical screening and self-assessment tool, particularly for micro, small, and medium-sized enterprise. Sector-specific version has been developed for stonework, aggregate plants, dental laboratories, tile production, and ceramic manufacturing. The method examines the material being processed, the task performed, the dust generation condition, the duration of the exposure, the work practice, ventilation, and control measure. ECRES has an important advantage. It allows intervention to begin even when quantitative measurements are not immediately available. However, it must not be misunderstood. A qualitative tool does not replace representative personal sampling when quantitative assessment is required. Its great value is prioritization, identifying high-risk workplaces and tasks that need urgent technical assistance, measure, and control. Environmental and medical surveillance are of limited value when the information remains in disconnected reports. Chile, therefore, developed a vast silica within the National CISESAT information system. It can record hazard identifications, qualitative assessment, quantitative measurements, similar exposure groups, worker roster, prescriber measure, and verification of this implementation. A particularly valued feature of the Chilean regulation is the requirement to transfer surveillance information when an employer changes occupational insurance administrator or when the worker changes employment but remains exposed. The transfer information may include environmental assessment from the previous 5 years, exposed worker list, the worker exposure category, and the date of the most recent ILO chest radiograph. The Chilean system also recognized that the risk does not disappear when the exposure ends. Post-occupational surveillance is generally performed every 5 years for up to 15 years after the definite cessation of the exposure. The surveillance system should follow the worker, not only the employment contract. Chilean medical surveillance includes chest radiography, of course, performed according to the ILO International Classification of Radiograph of Pneumoconiosis. Depending on the level of exposure, surveillance radiographs are generally performed every 1 or 2 years. Very high exposures requires early evaluation and annual follow-up. However, ordering a chest radiograph is not enough. The image might be incorrectly positioned, underexposed, overexposed, poorly identified, or interpreted in the wrong way. PECASI, the External Quality Assessment Program for service related to silicosis, was created to establish uniform quality criteria for chest radiograph and other surveillance service. It evaluates technical quality, equipment, personnel, competency, imaging acquisition, reporting, and traceability. A poor quality image is not a minor administrative problem. It can delay the recognition of an irreversible disease for years. Chile has also strengthened the reader training through international cooperation. For example, this year in 2026, the ISP, ICOH, the University of Illinois Chicago, the International Pneumoconiosis Observatory, and other partners complete the second Chilean reading training course, as you can see in that picture. So what's happening in Chile with all these government's plans to manage this risk? By the end of 2024, Chile had identified 33,143 workplaces with potential silica exposure. Approximately 84.9% had at least one qualitative assessment. However, only 7.9% had a quantitative assessment, and 8.6% were included in health surveillance. 627 workplaces had one or more assessment classified as risk level 4, representing exposure above the permissible limits or another critical risk condition. Cumulatively, 94,409 workers have received health evaluation. These numbers reveal both progress but an important implementation gap, because Chile has become relatively effective at identifying workplace where silica may be present, but identification is advancing much faster than quantitative characterization and medical surveillance coverage. In 2024, the target was to evaluate 8,393 new employers and entities, but only 2,700 were recorded in the EVAST system, approximately 32.4% of the target. The lesson is not that the model has failed. The lesson is that a technically advanced architecture still requires sufficient resources, coordination, inspection, and operational capacity. It's important to remember also that potential exposure is not the same as measured exposure, and measured exposure is not the same as controlled exposure. So the health effects of inorganic dust should not be reduced to the presence or absence of small radiological opacity. As we have seen in the previous presentation, silica exposure is associated not only with silicosis, but also with chronic obstructive pulmonary disease, chronic bronchitis, lung cancer, tuberculosis, and autoimmune disease. Chile also has a historical burden of coal workers' pneumoconiosis, as well as pleural and malignant disease related to asbestos. One Chilean mortality study identified 438 deaths attributed to silica-related pneumoconiosis among people aged 45 and older between 2017 and 2022. The highest regional rates occur in historically mining-intensive areas, particularly Atacama and Coquimbo. At the extreme clinical end, Chilean physicians reported that of 38 lung transplants performed at one specialist center between 1999 and 2006 were required because of advanced silicosis. These cases remind us that a fully preventable occupational disease can eventually require one of the most complex and expensive treatments in modern medicine. Occupational surveillance cannot be separated from social protection. Chile's law provides prevention, medical care, rehabilitation, economic benefits, and compensation for protected workers with occupational accident and disease. In 2024, approximately 7.25 million workers were protected by this insurance, representing about the 78% of the employee population. This is a significant strength compared with many countries in the region or in the globe, but approximately 1/4 of the Chilean employment remains informal. Informality is especially relevant in small construction projects, demolition, stonework, independent trades, and workshops. In a long latency disease, formality becomes an epidemiological variable. It determines whether an employer can be identified, whether exposure measurement exists, whether the worker was placed under surveillance, or whether future compensation is possible. Chilean silica regulation requires surveillance records and radiographs to be retained for decades, generally at least 30 years after employment or exposure ends. Without those records, the worker may eventually have a diagnosis, but no documented pathway connecting the disease with the workplace. Spain, we all know this, but I'm going to remind this. Spain demonstrated the re-emergence of silicosis in the new industries. In 2024, Spain recorded 520 occupational disease reports for silicosis. Between 2007 and 2024, the total reached to 5,900 reports. The number reported between 2015 and 2019 was more than 40 times higher than during the 19th and 1994. Many cases are linked to engineering quartz and natural stone processing. These workers are often younger and may develop accelerated and severe disease after relatively short exposures. There is also an important financing issue. Spain's national health system funded approximately 97.5% of silicosis-related healthcare process between 1997 and 2020. The same official analysis identified 5,400 deaths from silicosis between 19 and 2020. This means that when occupational prevention and recognition are insufficient, the public health system may absorb most of the clinical cost. Australia adopted a more radical response. From July 2024, it prohibited the manufacture, supply, processing, and installation of engineering stone benchtop panels and slabs. Australia became the first country in the world to introduce a nationwide prohibition of this type. Importation was prohibited later from January 2025. So Spain documented the re-emergence of the epidemic, and Australia decided to eliminate the highest risk product. China and India illustrate two different surveillance challenges. In 2023, China officially reported 8,051 new occupational pneumoconiosis cases. It also reported 21.88 million occupational health examination records. That's amazing. 5,670 examination institutions, 620 diagnosis institutions, and 829 pneumoconiosis rehabilitation centers. These figures demonstrate an extraordinary institution big scale. However, a high number of examinations does not automatically prove effective prevention. The critical indicators are always the reduction in workplace concentration, cumulative exposure, and future disease incidence. India has a different problem. Exposure often occurs in small quarries, stone crushing operation, and informal workshops. Many workers lack stable contracts, employment record, exposure histories, and access to compensation. India's National Human Rights Commission has recognized inconsistent implementation across states and the difficulty informal workers face when seeking diagnosis for compensation. So China chose that the challenge of covering surveillance scale into prevention, and India chose what happens when the exposed worker remain invisible. South Africa. South Africa provides one of the most important African examples because silica exposure is connected with gold mining, tuberculosis, migrant labor, and compensation for former miners. In 2024, active mining operation reported 136 cases of silicosis. 13 of these cases of silicosis were associated with tuberculosis and 746 cases of pulmonary tuberculosis. So gold mining accounted for 120 of the total of 136 silicosis cases. These figures should not be interpreted as total national burden. The greatest challenge may be former workers, retired miners, and migrants miners who return to the neighbor countries before their disease become clinically evident. South Africa therefore demonstrates that occupational surveillance cannot end at the mine gate. When we compare all these countries, we see different pieces of the same problem. Chile demonstrates the value of integrating environmental vigilance, surveillance, medical surveillance, diagnosis quality, electronic traceability, and social insurance. Spain demonstrates that silicosis can re-emerge through new materials. Australia demonstrates the use of elimination. China demonstrates surveillance at a big scale. India demonstrates consequence of informality. South Africa demonstrates the importance of tuberculosis, migration, and long-term follow-up. I would like to finish with a sentence that summarizes the Chilean experience. So, silicosis is prevented in the air, suspected through occupational history, confirmed through standardized diagnostic methods, and repair through social protection. We will not eradicate silicosis by counting advanced disease. We will eradicate it by identifying exposure early, controlling it effectively, ensuring diagnostic quality, and never losing the worker from surveillance. Thank you very much.
Thank you, Dr. Fernando, for such a great presentation and for sharing not only the national plan from Chile, but also your hard work and experience from the International Pneumoconiosis Observatory that you and your team are currently working. So we really appreciate that. And we would like to invite the attendees to make questions in the chat or prepare your questions to make them at the last part of this webinar. So thanks, Dr. Fernando and Dr. Diamen. Now we are going to move to our next speaker, which is Dr. Liliana. Let me share with you the Dr. Liliana is representing the Scientific Committee of Occupational Medicine. She is an occupational medicine physician with public health degree, public health studies, recognized experience in the Directorate of Public Health, Bucharest, under the Ministry of Health. She is from Romania. In over 30 years, she has been principal investigator in projects and regional coordinator of the Occupational Health Department. She's an occupational medicine, occupational health expert from the Ministry of Health in the technical committees for formulating points of view on European directives, trainer for medical residents accredited by the Ministry of Health and the Ministry of Education. She is part of the steering committee of the Scientific Committee of Occupational Medicine of ICOH. She has also been in the WHO Occupational Health Network contact point for Romania. She was the National Secretary of ICOH in Romania in the period 2010 to 2015, and she is the founding member of the Southeast European Network for Workers' Health. She received the Excellence Award for the entire professional activity in the field of occupational health, received it in 2025 from the Romanian Association for Occupational Safety and Health. I will check if Dr. Liliana is connected because she had problems with her Wi-Fi. Okay, I think she was not able to make it, but we have shared with you, with all of you in the chat, the presentation in PDF, so you can open it in as a backup. I have a video from her with a message about her presentation, so let me check if this can work. Okay, so I'm going to share with you the video, the screen and the audio too, and let me check if this works. I'm going to play the video. Please let me know if it works or not, especially the audio.
Greetings from Romania. Thank you for the invitation.
So, does it work?
It's frozen somehow.
Let me check.
And for your excellent introduction.
Oh, now it's okay.
Yes? Okay, great. So, everybody, you can open the PDF file that you have in the chat, and I will share with you this video.
On behalf of the Scientific Committee of Occupational Health and ICOH, which has 175 members from all continents, I wish you all good health and a successful professional career. The second slide, please. I have no conflicts of interest to disclose for today. As I am currently working in the Directorates of Public Health under the Ministry of Health, I have to inform you about these Directorates of Public Health. These are the sanitary administrative institutions under the direct management of the Ministry of Health in our 40 countries, and in particular for the capital of Romania, Bucharest. The network of this institution has autonomy and executive power to implement specific health programs for the environment, for occupational medicine, like health surveillance linked to the working conditions in the workplaces with chemical risk, new substances, new technologies, and much more. The third slide, please. Looking at this synthetic diagram on social development at local, regional, national, and European levels, I think and recall the old statement, prevention is better than cure. Workers' health policies focus on specific intervention and instruments, both on exposure to chemical agents in the work environment, such as prevention and promotion, and on medical surveillance with specific analysis of chemical determinants of diseases. Detailed information on each dangerous substances to encourage changes in the behavior of workers and employers, manufacturers, and politicians. Slide 4, the next one. In the well-known diagram of the total workers concept, we illustrate hierarchical control focused on elimination, substitution, and prevention, but to emphasize the breadth of work culture mechanisms necessary for promoting health in the workplace, especially for the efficiency of a chemical risk prevention, since chemical agents are over 570 well-regulated substances. Slide 5. Since we must have the same meaning of risk, we have to put some definitions. In general, risk is the probability of a negative outcome, the potential impact of a hazards event determined by the combination of the probability of the hazards occurring and the severity of effect. Hazards is anything that can cause
gentlemen.
In occupational health, risk is the probability and severity of an injury or illness that occurs as a result of exposure to a hazard.
Sorry.
I gave a talk in this webinar, but it's still going on, but we can talk. You know, it was just, now it's a video we're listening to, but can still talk.
Oh, yes, she's, I think that she filmed the video without the slides transition. So we are going to share, well, we have already shared the slide presentation in the chat, and we are going to upload both the video and the slide presentation to send it, will be sent by email, both of them.
Okay.
Okay.
Okay. That's all right.
So this video is not so long, and when it's finished, we are going to ask the attendees for making questions to the speakers that are already connected. Okay. Okay. Thank you, Professor.
Occupational risk assessment consists in determining the quantitative or qualitative value of the risk in correlation with the concrete situation recognized as a threat. It is the first step in the management process. In epidemiology and medical research, the risk is a probability that an individual will get the disease. It is an individual indicator. Here, the correct term is population at risk, because population risk is used in the cost-benefit analysis.
Actually, I follow you. I follow you on LinkedIn.
Oh,
I follow you on LinkedIn. Yeah, I've seen it. Yeah.
Hi, Professor. Oh, okay.
It is acceptable or not. We have a relative risk and attributable risk by comparing the incidence rates for acute events like intoxication, or for comparing the prevalence rates like chronic events, silicosis, in the study group and in the control group. Slide 6. Here, a global perspective on the system for the health of workers exposed to chemical risk. Legislation is covered by European directives, the chemical agents, classification of dangerous substances, carcinogen, mutagen, reprotoxic, implementation in the national legislation. We have standards for laboratories, engineering control requirements, regulation for work environment monitoring providers, and occupational medicine providers. Of course, a list of occupational exposure limit values. The main institutions are as follows at the international level: European Agency for Safety and Health at Work, WHO, Occupational Health Network, ICOH, ILO, European Chemicals Agency, and at the national level, ministries, providers, health authorities, inspection body, networks of professionals in occupational safety and health, occupational medicine, hospital of occupational medicine. Today I bring in front of you some interventions and tools which influence the framework of workers' health surveillance for chemical risk monitoring and biomarkers. These are national.
And actually, that's why I promote all the time. You know, I always promote teamwork. There's no way you can do this in silo. I just gave it this webinar. I mean, I had a talk for 20 minutes, and I was talking about GHS and SDS and the use of chemicals and the whole thing. And I said, you know, we need teamwork. We can't just work as a doctor or a nurse just on our own. We need industrial hygienists, we need safety professionals, we need, you know, I always promote this because it's very important. Yeah.
I think
people lose sight of that.
An open mic and doesn't know that yet.
Hi, Professor Jean-Pierre. Oh, sorry, can you hear me well? Since now we will still have our speakers connected, I think that we will skip the video, we will share it later. And since you are connected, if you agree, we can invite people to make questions and to interact with the speakers, which will be more fruitful. Yep.
Perfect.
Yeah. Sorry, thank you. So now I will stop sharing, and we will send this. And please, I know that Professor Mohammed is just in time, and Professor Jean-Pierre is also connected, and Dr. Diemen and Dr. Fernando are also up to questions. So please feel free to make questions to our speakers in English or in Spanish, and we can help you with the translation. Okay, so I would like to start. I don't know if Professor Mohammed is also connected. We have seen presentations about pneumoconiosis, but also about allergic and occupational asthma. So, have you already managed cases in which workers were diagnosed with occupational asthma and some years later they were under diagnosis of pneumoconiosis? Because in countries as Peru, we have a high under-reporting of pneumoconiosis, of occupational asthma cases. We do have reports from pneumoconiosis cases, but not so often the occupational asthma cases are reported.
Yeah, here in Chile, the only study that tried to link these two pathologies, pneumoconiosis, but was not asthma, was chronic obstructive pulmonary disease. The study tried to link the exposure to inorganic dust with an increase of the incidence of the diagnosis of the COPD. But with asthma, I think we got nothing for now, I think.
Okay, thank you. And what about you, Professor Mohammed, based on your experience in occupational asthma? I think your microphone it's not working, Professor Mohammed. Oh, I think. Hi, Professor Mohammed, can you hear us? Hi, Professor Mohammed, can you hear us now?
Yes, I can hear you now. Yes.
Oh, thank you. I will make you the question. It was
Okay.
based on your experience, especially in occupational asthma. Have you already managed cases of workers who had a diagnosis of occupational asthma and some years later they were continue exposed to dust, silica dust, and they were under the diagnosis of pneumoconiosis?
No, actually not. I've seen and managed patients with occupational asthma on the one hand, and I have seen patients with pneumoconiosis on the other, but I haven't seen any patients with both occupational asthma and pneumoconiosis together. In our experience in the mining industry, we don't see much of occupational asthma except for platinum salt sensitivity. So refinery platinum mines that refine platinum salts, they have occupational asthma from platinum salts. And so in those kind of instances, you will see the asthma, but then the incidence of pneumoconiosis is very low, or actually non-existent in terms of platinum mining, except for tuberculosis, which is a problem throughout the mining industry in South Africa. Although, as Fernando mentioned, the incidence is much higher in gold mining industry, where a high proportion of workers develop TB either with or without silicosis.
Thank you, Profesor Mohamed. Tal vez alguien de de los participantes que quieran hacer preguntas y los podemos ayudar con la traducción al inglés. I would like to make another question to maybe Dr. Diemen and Professor Jambier. Based on on the presentation you already delivered, Dr. Diemen, there are some differential diagnoses we should work on. When we talk about silicosis, you were very clear about beyond the silicosis, there are a very complex lung disease with different diagnoses we have to consider. In Latin America, besides silicosis, which have been the most frequent diseases, lung diseases, that you have faced in the diagnosis process? Tal vez, doctor Diemen, en base a su experiencia en Latinoamérica, ¿cuáles han sido las enfermedades pulmonares con las que mayormente ha tenido que hacer el diagnóstico diferencial con la silicosis?
Ok, muchas gracias por la pregunta, doctor Norville. A ver, todos están en conocimiento que la silicosis es como una cuestión mitológica, eh, que no existe o que está siendo abordada por aseguradoras específicas en cada uno de los países, lo que esto ha hecho que los clínicos a nivel global, y voy a hablar más bien a nivel de América, se enfoquen más bien al tratamiento y no al origen de la causa, la cual uno puede descartarla, ¿cierto? A través de exámenes, como bien lo dijo el profesor Mohamed David, a través de una hemoglobina específica, a través de una espirometría, a través de una test de metacolina y la historia ocupacional, fácilmente uno lo puede asociar a ello. En el caso de las neumoconiosis, de la silicosis, tenemos una brecha pero gigantesca, ya que tanto las universidades, tanto en la formación de pregrado y de posgrado, no dan un material o un contenido importante de lo que es la salud ocupacional respiratoria. Entonces, hay un gran déficit acá en lo que es América. Y bueno, ahí está la pregunta también para a la doctora Javier Gazana y también para el doctor Mohamed Yexi. ¿Qué ocurre en sus países de orígenes? Entonces, el diagnóstico diferencial, doctor Novil, a su respuesta, y voy a hablar específicamente de lo que es Chile, no es fácil porque existe una especie de divorcio entre la parte clínica y la parte ocupacional, y cada uno se dedica a ejecutar cierto su accionar. Por ejemplo, en la parte de la aseguradora es el diagnóstico, en este caso, y todo lo que son las prestaciones económicas, mientras que en la parte clínica solamente se enfoca en confirmar si es una patología de tipo inmunológica o una colagenopatía o algún factor biológico o viral que puede provocar una neumonitis por hiperplicidad, en este caso el vario, eh, pero no llegan a un diagnóstico certero en cuanto a descartarlo como una patología ocupacional. Por lo tanto, la brecha está muy gigante y yo creo que lo que hay fortalecer es la educación de pregrado y de posgrado. Si a mí me dices en este momento, doctor Delgado, si yo le someto a una radiografía de tórax con técnica OIT, ya nos hemos dado cuenta que esas opacidades redondas se pueden confundir con un sinnúmero de patologías, es decir, lo que se llama estas neumoconiosis simuladoras, y por lo tanto se requiere mayor capacitación, mayor entrenamiento con la formación de médicos virril a través de la NIOSH o a través de formaciones que se hacen en Japón, también con esta técnica. y poder ir fortaleciendo el diagnóstico diferencial y a su vez convencer, ¿cierto?, a las sociedades científicas clínicas de neumólogos, de reumatólogos, de radiólogos, de que existen patologías que ellos todavía no tienen esa capacidad de poder diferenciar con otro tipo de técnica que es la radiografía OIT y no llevarnos, ¿cierto?, a una biopsia pulmonar como ocurrió con el caso que presenté anteriormente.
Muchas gracias, doctor Yemen. En relación a ello, tenemos una pregunta en el chat de la doctora Mónica Vázquez. Se pregunta acerca de si han logrado identificar casos de neumoconiosis en trabajadores de minería artesanal. Porque estos trabajadores probablemente no asisten a un centro de salud del Seguro Social, probablemente asisten a un centro de salud pública. Si es que han logrado identificar este tipo de trabajadores y si es que estos casos los considerarían como un problema de salud pública. For our speakers in English, there's a question in the chat from Dr. Monica Vasquez, who is asking about if any of the speakers has identified pneumoconiosis cases in artisanal mining, and if these workers who has not a social health insurance, they can go to a medical center who is not from the social insurance, and if those cases are managed as public health problems or public health cases. Está abierta la pregunta para cualquiera de los expositores. It is up to any of the speakers.
I would like to start to respond. This is a classic problem because this is the problem of the sub-notification, the sub-registry, that finally the common health system absorbs the cost of the treatment, and the social service must found this patient, but because the informality, there's no labor contract, so there's no medical surveillance, so there's nothing. So these poor people come to the common health system, and the common health system absorb this. So yes, it's a big problem, but it's linked with informality. This question is linked with the informality. I don't know if Professor Jibe want to say something more.
No, I agree with you 100%. I mean, we have the same challenges in South Africa as well. Gold mining has been and still is institutionalized only in the formal sector. But we know and we are aware of workers doing artisanal mining, illegal mining in unused dumps, mines that were not rehabilitated, so workers then go and try and extract leftover gold, tailings, and so on. And these workers are not covered by any laws, and therefore they are not monitored, and therefore they would not be eligible for compensation because they are not registered by the mines or so on. So it's a big challenge. However, in South Africa, we have a system where a worker, an ex-miner, could go to any public health facility and obtain an X-ray if they did, mining in the past. And so that is a benefit that is provided to any ex-miner. The problem is that workers don't know of these rights, or they live in areas where they don't have access to health facilities, where there are experienced doctors who would identify them as having pneumoconiosis, and every second miner is classified as having TB, even though underlying there may also be silicosis and so on. So it's a big problem of underdetection, and therefore they are not protected adequately.
Thank you both. I for sharing these experiences. We have another question. You have you have talked about a globally harmonized system of classification and labeling of chemicals. So comparing the sectors such as agriculture, construction, mining, and others, which have been the most difficult barriers in the implementation of this system, Professor Jambier? Professor Jambier, can you hear us?
Yes, I do. Can you repeat the question?
Yes. If we compare some of the sectors you deliver in your presentation, you talk about it in your presentation, which have been the most difficult barriers in the implementation of this system?
You mean for different countries?
Yes.
Yeah, where it's basically what happens here. It is like most of these ILO convention and recommendations. It depends on the countries. So some countries already sign off on. I mean, they abide by those ILO recommendation conventions. They pretty much do a good job when it comes to implementation of GHS and SDS. Those who didn't have a hard time because you get to be doing, basically he had accepted our concept, and then because basically GHS and SDS they're embedded in any country's law, and that's what we're trying to do. That's why many countries actually you won't allow them to change, some categories and classes because they would like them to go along with the laws. Okay, but if the countries didn't even abide by any of those convention and recommendations, you don't really expect much, which is unfortunate. But but if a country was able to go along, then the implementation becomes easier. You know, that's why you saw many countries in Europe and in America, they've done a wonderful job. But when you look at the Africa and Middle East, you saw the map, the whole thing was red because most of these countries didn't abide by these ILO convention and recommendations, you know. And that's still a big problem with ILO, you know. And nobody really knows how to really, they're pushing, the ILO try to push, but some countries already started, and but it's a long process, and that's really what happens with GHS and SDS. And nowadays, most of the businesses are moving into the global south. This is the time really to push, because otherwise, the workers will be exposed to chemicals, and they will suffer more. There will be there will be more illnesses, diseases, and then even mortality, because we don't have those. We don't follow the global harmonized system. And you saw we have about 40 chemicals every hour being manufactured. How do you deal with these chemicals? Most of it, we don't even know. We don't have really the studies on their toxicity. So that's I don't know. Maybe through ILO, there's maybe ICOH. Any way we can help individual countries to go along with those. That's just my take on this. It's a very challenging issue. So yeah.
Thanks, Professor Jambier. So, how do differing local country adoptions of the global harmonized guidelines, global harmonized system guidelines, impact international chemical supply chains and shipping?
Oh, that's actually, you see, that's the other it goes along with this one. Because see, in my conclusion, what I did, I showed how when you're a company, like the one I was working for 5 years, John Credit International seeding company in Chicago, we would send those chemicals to different other companies because this was about the chemicals were creating. This John Crane International seeding company was, they are specialists making the joints and of like whatever you use in cars and airplanes or whatever, and they make sure there is no leak, and and you have to use chemical to use this. And then what happens, the contractors, the suppliers, and the downstream people, you got to be able to provide to them, to provide them with the similar safety data sheet, But as I did my work and I spent 8 years in Kuwait, I used to talk to companies and have a lot of contractors, And as contractors, when you approach them, hey, I mean, I see your workers, mostly migrant workers, they are being exposed, Oh, no, that's not my problem. I'm a contractor, so you got to talk to the company. And you talk to the company says, oh, yeah, this is an issue with the contractors. So you become like a ping pong ball or a tennis ball, and that's had to be resolved, at the country level, where you tell companies, look, if you're in charge of delivering chemicals, making chemicals, you got to make sure even the ones you supply the chemicals to, you're talking about the suppliers and the downstream users, you got to still provide them with, these safety data sheet from following the global harmonized system. Again, those are issues we see in Africa and then in the Middle East, but in other countries, and I was recently in Indonesia, and they seem to do a pretty good job. And they were like Peru, they were in basically bluish color. The green was Colombia is green, like European countries, and so that's something that's need to be worked on by, I don't know, through ICOH and then ILO, trying to find a way of having these countries going along. It's not an easy job. Thank you.
Thank you, Professor Jean-Pierre. We invite any other of the attendees to make any question. For the speakers, you can prepare your final message about this webinar or about the topic that you already delivered. We would like to express our gratitude to Professor Jean-Pierre Gassana, who is representing the Scientific Committee of Occupational Health in the Chemical Industry, and of course, the Chair, Dr. Esai, and Dr. Rajesh as ICOH board member for joining us in this meeting. We would also like to thank Professor Mohamed Yibhai, who is member of the Scientific Committee of Occupational Medicine, for sharing his research, his hard work on asthma and allergic. And of course, we would like to express our gratitude to Dr. Diemen Delgado and Dr. Fernando Peñafiel, representing the International Pneumoconiosis Observatory, for sharing the hard work you are doing currently and to more visibility of the pneumoconiosis worldwide, and the prevention that we still need to work on this very complex disease. So we would like to invite Professor Mohamed for a final message about the topic you delivered.
I think my main message is that we need to have a high index of suspicion for diseases, airways diseases, such as occupational allergy and asthma. And we need to ensure that doctors and other health workers are trained to be able to recognize these diseases so that we can identify them and we can better manage workers who may be affected with airways disease. Thanks.
Thank you, Professor Mohammed. We would like to invite Professor Jambier for also sharing us your final message, statement about the global harmonized system.
Where my really final comments about this use of GHS and SDS, and it's really to work closely. I think ICO can really help in this regard. Many other international organizations of occupational health, making sure that ILO will be able to approach countries, because you remember in my introductory comments, I mentioned the fact that U.S. dragged their feet. They didn't want to really go along with UN, global harmonized system, globally harmonized system. But at one point they were, because a lot of negotiation between ILO and the United States and NIOSH, the National Institute of Occupational Health in the US, and then OSHA, which is a Occupational Safety and Health Agency, finally they did. And when they did, actually, it really made life easier for many countries, because there are a lot of companies in the U.S. making those chemicals. They export them to different countries, and and that was very, very helpful. So I think the best way to just work with is an international organization, especially ICO, WHO, and then having ILO to see if they can make a dent in making sure that countries follow through. No, not just I showed you the basically how you embed global harmonized system, SDS, into those ILO recommendation and conventions. So if they really do abide by those, then it'd be easier for them to go along. Like I said, because many companies are removing to global south, they're moving into Africa to Middle East, and that's really the time to do this. So I'm hoping the ICO 2027 in Mumbai we add, some basically flavor to this topic, which is crucial to me. In fact, we have a special panel on GHS and SDS also in Mumbai next February. Thank you.
Thank you, Professor Jambier. And now we would like to invite maybe Dr. Diemen or Dr. Fernando, any one of you who would like to give your final statement.
Yes, I would like to conclude that to eliminate the pneumoconiosis, as we see in my presentation, requires coordinated effort, actions across governments, institutions, private workers, tripartite tables to discuss how to abort in a more optimal way, and development a strong national plan. Private organization has IPO or OIN are also play an important role by connecting national efforts with leading international institutions, for example, NIOSH. Finally, the comment that Dr. Vasquez made previously about that we must not forget the informal workers who often remain outside surveillance and protection system. I don't know the answer. I don't know how to each country has to determine how to treat and how to absorb the cost finally of these workers that are not in the formal social security system. So that's the challenge, I think.
Thank you, Dr. Dr. Fernando, and maybe Dr. Diemen would also like to share with us your final comments.
Bueno, solamente agradecer por la convocatoria de ICOH a esta reunión académica con brillantes expositores. Un gusto conocerlos y el Observatorio Internacional de Pneumoconiosis está a su disposición para poder trabajar de manera conjunta, para poder intercambiar conocimientos, materiales, lo que ustedes gusten. Muchas gracias por la invitación y que tengan una buena tarde, buenas noches, donde estén ustedes por allá.
Gracias, Dr. Clement. Thank you so much to everyone. We're going to share with all of us the recording, sending you the link in our YouTube channel. So please make sure that you can fulfill the form that we already sent in the chat. Thanks, Professor Jean-Pierre, Professor Mohamed, and Dr. Fernando and Yemen. Thanks to everybody for
Thank you,
joining us
Dr.
in this
Norvin.
webinar.
This is wonderful.
Thank you,
talk.
everyone. And lovely meeting all of you. And hope to
Yes.
see you again sometime.
Yep.
Bye-bye.
Thank you,
Looking
Professor.
forward to meeting you
Thank you.
again. Thank you, Professor Mohamed, Professor Jean-Pierre,
Thank you.
and Dr.
Thank you,
Fernando Yemen.
Fernando. Yeah. Thanks. Bye-bye.
Bye.
Bye.